of pain in his hand. This doctor behaved rudely with him and asked to shut up. Now, why is this change from doctors being addressed as a point to doctors being beaten up and violence against doctor in the present scenario? Why is there fading of doctor-patient relationship? Okay. In the first scenario, there was proper doctor-patient relationship, but in the second scenario, there was no proper doctor-patient relationship. We shall see what was wrong. So here, on one hand, Dr. Ramappa showed all the features of all the proper features in doctor-patient relationship. But Dr. Shyam, in his case, patient autonomy, fiduciary care, trust, empathy, and boundaries were missing. Now, does this mean there were no violence against doctors in the past, or are there no empathetic doctors in the present? So nothing like that. There were violences in the past also, and even today we have empathetic doctors among us. So, but both in less numbers. In the past, empathy, trust, professional boundaries, and shared responsibilities, which were at peak, have come down in the present scenario, with which the violences which were at very less number in the past have come to peak in the present scenario. Now we shall head to the future to see what will happen in the future. Oh, there is some problem in the time machine. So by the time it gets fixed, let us look into the aspects that really matter a lot in the doctor-patient relationship. Before that, why is it important to know all this? It is because one is increasing litigations against doctors, increasing violence against doctors. I agree that patient mentality and patient attendance anxiety also contribute to violence. But here, studies have shown that even lack of empathy, trust, and all, they have also contributed to violence against workers. Also, it is important for achieving better health outcomes for the patient. Now, a patient says, my doctor heals me. Doctor listens to me while no one else. I can share my problems with him comfortably. What if instead a patient says, it feels like you are just trying to push another expensive prescription, or doctor just wants money. So in the first two conversations, we can see the patient has faith in the doctor, but in the second two conversations, we can see that the patient is having no faith in the doctor and he is of the opinion that doctor is not doing anything good to me. Here comes the context of trust in relationship. So what is trust? It is a key element in doctor-patient relationship. It involves patient's faith in the doctor's competence and caring, as well as the doctor's trust in the patient and his or her beliefs and report of symptoms. Now, there are many factors that affect trust of patients towards their doctors. If the doctor is given limited time during consultation, or the doctors are being changed frequently in the hospital, or if physician is not frequent in visiting the patients, if physician is not listening properly to the patient, patients are rushed during consultation, or poor or insufficient feedback from the physician, if the physician is interrupting the patient's thought, if the patient is trying to tell something and if the physician says stop, it's okay, or if he is dominating the session, you have to follow what I say. There is no, if he's not giving any options to the patient, then eventually the patients will lose trust in the doctors. However, providing ample time for the patient to share his problems or frequently interacting with the patients, giving proper feedback to the patients, showing interest in listening to the patients, being empathetic towards the patient, respecting patient autonomy, that is, even the patients have choice in selecting the treatment, and maintaining clear boundaries in the doctor-patient relationship. These can increase patient trust in the doctor. Now, on one side, we can see that is paternalism, where the doctor is dominating the clinical decision making. He is not giving options to the patient, but he is only deciding everything. On the other hand, the patient is deciding everything, and doctor is just agreeing to what patient is saying. That is hyperautonomy. So both are not ideal. Here is the role of shared responsibilities in clinical decision making. Here, doctors and patients should contribute equally in clinical decision making. However, it is not necessary that both have to follow the same responsibilities. Even this is not possible because doctors have knowledge, but patients do not have medical knowledge. So they follow their own responsibilities. So what are those? Doctors are responsible for providing healthcare services, prioritizing patient safety and well-being, keeping the patient informed about his or her condition, then advocating for the patient's best interest. That is, acquiring knowledge and skills to provide the best possible care. Now, what should the patient do in this shared responsibility part? The patients are responsible for following treatment programs, thoughtfully selecting the treatment among the options provided to them, giving complete and truthful information. They are also required to request information or clarification for for the things they are not understood, and thus they need to engage actively in understanding and clinical decision making. Now, coming to fiduciary care. So, a fiduciary is a person who is entrusted with power over legal or practical interests of the beneficiaries. So, here in clinical context, the physician is the fiduciary and the patients are the beneficiaries. Because physicians are granted discretion as they are committed to use their special knowledge and skills for the benefit of their patients. They are bound by a duty of care, loyalty, and good faith towards the patients. Here, the patients are the beneficiaries as they lack sufficient knowledge and skills to solve their problems. Hence, they have faith in the physicians and they rely in the physicians. It is important to note that though physicians and patients are given different levels, that is fiduciary and beneficiaries, it is not paternalism. In paternalism, the doctor decides the treatment alone, but here there is, though there is asymmetry between doctor and patients, the flow is directed towards the patient. Whatever the doctor does, he does for the good of the patient. He discusses all the treatment options. He also addresses the spoken demands and unspoken demands of the patients. Spoken demands like the patient wants to get cured of the disease, but unspoken demand is the patient wants to know the risks of the treatment, but he will not ask. So here in fiduciary care, the doctor understands both spoken and unspoken demands of the patient. Hence, it is not paternalism. Now, empathy. Empathy is a powerful element that facilitates treatment effectiveness. So, what is empathy then? It is the ability to understand patient's personal experience without bonding them. Though they are not bonded, though they don't have any bonding with the doctor has the ability to understand patient's personal experience. That is empathy. So, emotional, cognitive, and behavioral aspects of communication skills also add on to empathy towards the patients. Studies have shown that doctors who are empathetic towards their patient are more efficient in the clinical practice. So, what does this mean? So, when the doctor is empathetic towards a patient, the patient gives proper history. He feels that the doctor is caring for me. He wants to solve my problem. So, they give proper history. They consent for examination and they stay compliant with the treatment. And doctors are also less likely to commit medical errors and suffer violence. Now, there are many factors hindering or favoring empathy towards patient at three different levels: organizational level, personal and interpersonal level, and demographic factors. We shall see each of them. So, lack of organizational support or huge number of patients and the doctors are having burnouts due to long working hours. Eventually, the doctors will be less empathetic towards the patient. However, training workshops and CMEs about empathy, like one we are a part of, they all favor empathy towards patients. Patient's behavior. If the patient is so much angry or if they are not cooperating, then the doctors will have less empathy. Then focus on therapy. If the doctor's mindset is only to treat the patients, if they are only trying to cure the disease, then eventually they will have less empathy. Experiential informal learning. So, what is this experiential informal learning? It is the development of genuine empathy towards a patient when the doctor has experienced similar conditions. Like the doctor might have experienced the similar disease, or he may be from this similar socioeconomic background. So, there will be more empathy in such cases. And demographic factors. Studies have shown that female doctors are more empathetic towards patients, and doctors who are highly experienced are more empathetic towards their patients. Now, boundaries in doctor-patient relationship. So, boundaries define the limit in doctor-patient relationship. Why is it important? It is important for maintaining the doctor's professionalism and to protect the dignity of the patient. Where and all it is important? It is important in cases of asking history or examination, wherein the doctor wants to know critical information like substance use or sexual or contraceptive history. So, why is it important to know boundaries in doctor-patient relationship? This is because physicians are held in great esteem and respect by the society. They belong to a noble profession. As I said in the beginning, Vaidyo Narayano Harihi, doctors are considered equal to God. It is a noble profession. It is not like any other profession. So it is important to maintain boundaries in doctor-patient relationship. So it is important for the doctors not to violate the boundaries. There are two types of boundary issues as identified by Guttel and Gabay. One is boundary crossing. It means minor excursions from the limit. Means there is minor excursion from the doctor-patient relationship. Here it is done for therapeutic connection or in good intention, such as accepting small, non-expensive gifts from patients only to make the patient feel happy, or attending personal events of the patients when invited to make the patient feel happy. So here the patient, if the doctor has accepted my invitation or he has accepted my gift, he treats me like a human being, not just like a patient. So here it has a constructive impact. It elevates interpersonal trust and satisfaction. On the other hand, we have boundary violation. It includes deviations from the line to exploit the doctor-patient relationship. Here, it has exploitative behavior serving the physician's personal benefit. Here, the physician is not doing anything good to the patient. Instead, it is for his own personal benefit. Examples: renting a flat from patient and paying him less, thinking that I am doctor, I will treat his disease, so I can not pay him properly. Or developing friendship with the patient, which may later turn into physical intimacy. It is called slippery slope. Once a person slips at a slope, he'll be slipping further. It usually has a destructive impact. It destroys therapeutic trust and severe legal risk. However, these are some examples from studies, and it again the examples depend on the clinical context. Either boundary crossing can be considered as boundary violations also in some scenarios. Now, what are the consequences of boundary violations? Why should boundaries be maintained? It is boundary violations will make the patients lose trust in the doctors, and also it will have a negative impact on doctor's name and fame. What the doctor did like that? What is this? And they feel like it. Devastating consequences of boundary violations, especially with regard to the opposite gender, will have severe legal issues. Now, how to prevent boundary violations? It can be done by understanding the principles behind managing boundaries in doctor-patient relationship and sensitizing doctors at early stage, as early as undergraduate and postgraduate level, regarding managing such boundaries, so that it will be easy for them in the future. Early recognition of boundary violation and prevention of its progression to physical intimacy. Then the physicians should avoid wearing inappropriate dress and avoid using abusive words in front of patients and sharing irrelevant personal data with them. So what is not needed for the patient, the doctor need not disclose all those personal data with the patients. Now, empathy, professional boundaries, trust, fiduciary care, shared responsibility, all these are not separate entities. They all are interconnected and they contribute to the doctor-patient relationship. Now, loss of trust, paternalism, no empathy, boundary violations are threats to the doctor-patient relationship. It seems we have received a mail. It is from the time travel agency. Our time machine is ready. Now we are ready to go to the future to see what will happen in the future. Okay. You see, it is very difficult to find proper doctor-patient relationship in the future. There is no empathy, no trust. Artificial intelligence is trying to replace doctors. Could artificial intelligence replace empathy and trust in doctor-patient relationship? So we don't know, but I don't think any artificial thing can replace natural human emotions. But could our future change? Can we still have proper doctor-patient relationship in the future? Yes, definitely. Our future is shaped based on what we do today. Now we'll come back to the present. Now, so early training of medicos determines what kind of doctors enter the society tomorrow. So how much the students are taught today, that many qualities will be reflected in the future. Empathy, trust, fiduciary duty, shared responsibilities, professional boundaries, if followed in practice, then doctor-patient relationship can be made better. So it is our duty as future doctors to pledge to ourselves to inculcate all these qualities in our practice. Now, getting degrees, earning money is definitely important, but also inculcating these skills of trust, fiduciary care, shared responsibilities, professional boundaries, and empathy are also equally important in clinical practice. Now, we should always remember to cure sometimes, to relieve often, and to comfort always. And treat a disease, you win, you lose. Treat a person, I guarantee you will win, no matter what the outcome. Now, patients don't care how much you know until they know how much you care. So patients do not see how much the doctor has earned degree, how much the doctor is famous or what. The patients see how well the doctor is behaving with them, how well the doctor is able to understand their problems, how well the doctor is able to make them feel comfortable. It is not possible to cure every disease. It is not possible to relieve every pain, but it is always possible to make the patients feel comfortable and feel that they are not some disease entities. They are also human beings like everyone. So these are my references. I'd like to thank these people for their constant support throughout this endeavor. Thank you.
Thank you for the enlightening presentation. Before we proceed, I would like to welcome our online participants. For your information, this was our second session. I now request our moderator, Dr. Priyadarshini Ma'am, to kindly share her remarks.
Respected dignitaries and all the dear students and my fellows. Thank you so much for giving us this opportunity for bringing out this topic. It's a very thoughtful topic for the CME. And another important thing is involving our students into the session would really bring a positive outcome among the students. That is the intent of doing CBME curriculum and including ad hoc sessions into the CBME curriculum. And I think Dhanvin has took us through this travel journey where he took us from past till the future, and he beautifully depicted what is the impact of having or building mutual trust among the patients. I mean, between the doctor and the patients, as well as the communication and showing empathy. I think that brings the foundation for the doctor-patient relationship. I think that has been very well depicted by him. Congratulations, Dhanvi. If you have any doubts to clarify, please do. We are open for your questions. Anybody, any doubts? And I would like to congratulate Dr. Nandini and her team for organizing such a beautiful CME. And I am really honored to be here. Thank you so much.
I request Ma'am to present token of appreciation to our speaker.
ಸೆಂಟ್ರಿಗೆ ಫೋಟೋ ಸರಿ ಬರೋದು ಸೆಂಟ್ರಿಗೆ ಇದು ಬರುತ್ತೆ.
I now request Dr. Kiran Kumar Sir, Chief Administrative Officer, to present memento to Dr. Priyadarshini Ma'am. Thank you, sir. Thank you, ma'am. We will now begin with our inauguration ceremony.
When there is righteousness in the heart, there is beauty in character. When there is beauty in character, there is harmony in home. When there is harmony in home, there is order in the nation. When there is order in the nation, there is peace in the world. These timeless words remind us that values shape professions and professions shape society. Satvata is not merely a CME, it is a celebration of the values that transform medical students into compassionate physicians. I now take immense pleasure in welcoming our dignitaries to the dais for the inauguration ceremony. I also invite Nandini ma'am to deliver the welcome address.
Sir, Kiran sir, Venkatesh sir on stage, and also Sudha ma'am, please on stage. Okay, good morning and warm welcome to all. Respected Chief Patron, guests of honor, faculty members, delegates, and dear friends. It is my privilege to welcome you to the Sadvrita, the implication of AdCom in medical education. True education is not just knowledge, but cultivation of values. As healthcare professionals, we must preserve dignity, earn trust, and uphold humanity. These are the core ideals of AdCom: attitude, ethics, and communication. Today's theme, Sadvrita, means righteous conduct, derived from Sat and Vrita. It is the ideal code of living rooted in Ayurveda. Acharyas like Charaka and Sushruta taught that healing needs ethics, compassion, and respect along with medicine. Though medical technology has evolved from palm leaves to artificial intelligence, the value of a good physician remains unchanged, with empathy, integrity, and patient welfare above all. Thus, perfectly aligns with AdCom. Attitude builds compassion, ethics guides decision, and communication strengthens the doctor-patient bond. So together, they transform competent graduates into consciousness healers. I sincerely hope that today's deliberation inspire all of us to embrace these timeless values in our daily professional lives and continue the legacy of compassionate, ethical, and patient-centered healthcare. Acknowledging the dignitaries on the dais, it is now proud privilege to warmly welcome our distinguished dignitaries who have graciously honored this occasion with their esteemed presence. First of all, I would like to welcome our Chief Patron. Although he was unable to join us today due to prior commitments, we are honored to acknowledge the gracious support of Dr. G. Parameshwara, Honorable Chancellor, Sahe, and Honorable Deputy Chief Minister, Government of Karnataka. So, who is our esteemed Chief Patron. And I also uh, is better after Mrs. Kanika Madam. We extend our sincere gratitude for their constant encouragement and guidance. I would like to welcome also our Dr. Lingegowda KB, Honorable Vice Chancellor Sahe. Due to his busy schedule, he couldn't make it up. So we welcome him in his absence. Dr. Ashok Mehta sir, Registrar Sahe. Again, he was like he couldn't make up for the event because he was busy. So we welcome in absentia. We welcome Dr. Sunil K, Controller of Examination, Sahe. Thank you, sir. Welcome Vivek Viraya sir. Even he couldn't make up for it because of busy thing. We welcome him in his absentia. We welcome Dr. Mallikarjun Sanikok sir, Principal, Sri Siddhartha Medical College, Tumkur. He's a backbone and very cheering leader for our event to happen. We welcome you, sir. Dr. Praveen B. Kudwa sir, Principal, Sri Siddhartha Medical College, Sahe. So thank you so much for the venue and like you really a great support. He's an inspiring leader too. Thank you so much, sir. Dr. Prabhakara GN sir, Vice Principal, Shri Siddhartha Medical College, Tumkur. Very kind-hearted, very friendly. Okay, so he's a backbone for all the students and faculties. We welcome you, sir. Thank you so much for coming. Dr. N.S. Venkatesh sir, Medical Superintendent, Shri Siddhartha Medical College Hospital. He is a main strength and support to extend our pharmacology to clinical side, along with our principals, Mallikarjun Sanikok sir and Prabhakar sir. We are doing our thing which is possible because of this pharmacovigilance and metro vigilance, which is taking baby steps, but it's happening in a big way. Thank you so much, sir. Dr. Rajeshwari Devi ma'am, Medical Superintendent, Shri Siddhartha Medical College Hospital. Thank you, ma'am. Thank you for your support. Welcome you, ma'am. Dr. Kiran Kumar, sir, Chief Administrative Officer, very knowledgeable, silent supporter, and very good guide. Thank you so much, sir. Thank you so much for your support. Thank you for your guidance too. Welcome you, sir. And I welcome the head of the department from Siddganga Medical College, Priyadarshini ma'am, and T. Begur, our Shri Siddhartha Institute of Medical Science, Dr. Lohit sir, and also HOD from Forensic Medicine, Sidramana sir, and also Pradeep sir from Siddhartha, and also Subramania sir. Please, we welcome you on stage, sir. Please come. Please, sir. One of the guests to talk. Then we welcome Dr. Sudha ma'am for the interactive session, which is going to be a wonderful session, humble soul, down to earth. I have no words to describe about her. Okay, very friendly. When she became HOD, she moved out of the college and she's attached to company now. Very wonderful. You can interact with her, whatever you want. You can talk to her. She just and merges with whoever meets in with contact with her. Okay, we welcome you, ma'am. And to our Subramania sir, all of you know him. He's a pediatric surgeon, humble, down to earth, very knowledgeable, very disciplined person. We are honored to have you here, sir. So you'll be interacting with him too. So these two are the main staff faculty who will be talking. And we also have a student speakers. We welcome all the student speakers and also organizing batch. Big round of applause for the organizing batch. A second MBBS student, that is the thing what we honor from them. It's a good thing. Every year, the second year students, they take initiative. We do push a little bit, okay, from the Department of Pharmacology. We get scoldings from them, but still, at the end, nothing happens unless we fight and come to one conclusion. So things happen in a beautiful way at the end of the day. So thank you all. I welcome all the delegates, faculties, our PG students. They are real support to me, Arvind and Hari, Priyanka, okay, and also Joan. Thank you so much. I welcome all of you. Thank you so much.
Thank you, Nandini ma'am. There is another Sanskrit saying, Tamaso ma Jyotirgamaya, lead us from darkness to light. The ceremonial lighting of the lamp symbolizes a triumph of knowledge over ignorance and compassion over indifference. I request our dignitaries to kindly light the lamp. Please rise for the Nada Gite.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरि
Please rise for the Nara Gite.
भारत जननीय तनुजाते जय हे कर्नाटक माते जय सुंदर नदी वन नारे जय हे ऋषि गणपति मकुट गगनमणि चंद्र चंद्र ಹೊನ್ನಿನ ಗಣಿ ರಾಘವ ಮಧುಸೂದನರವತರಿಸಿದ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜನನಿಯ ಜೋಗುಣ ವೇದನ ಘೋಷ ಜನನಿಗೆ ಜೀವವು ನಿನ್ನಾವೇಶ ಹಸುವಿನ ನೀರಯ ಸಾಯೇ ನಿನ್ನಯ ಕೊರಳಿನ ಮಾಯೆ ಕಪಿಲ ಪತಂಜಲ ಗೌತಮ ಜಿನನುತ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಶಂಕರ ರಮನುಜ ವಿದ್ಯಾರಣ್ಯ ಬಸವೇಶ್ವರ ಮಧ್ವರ ವಿದ್ಯಾರಣ್ಯ ರಂಗ ಶರಕ್ಷರಿ ಕೊಂಡ ಮಂಗಲ ಕುರಿಪತಿ ಚಂದ್ರ ಕುಮಾರ ವ್ಯಾಸರ ಮಂಗಳ ಧಾಮ ಕವಿ ಕೋಗಿಲೆಗಳ ಪುಣ್ಯಾರಾಮ ನಾಮಕ ರಾಮಾನಂದ ಕಬೀರರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಕೈರಕ ಹೊಯ್ಸಳ ರಾಣಿದ ನಾಡೆ ನಂದನ ಜತನರ ಮೆಚ್ಚಿನ ಬೀಡೆ ಕೃಷ್ಣ ಶ್ರಾವಣಿ ಗಂಗ ಕಾವೇರಿಯವರ ಗಂಗ ಚೈತನ್ಯ ಪರಮಹಂಸ ವಿವೇಕರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಸರ್ವ ಜನಾಂಗದ ಶಾಂತಿಯ ತೋಟ ರಸಿಕರ ಕಂಗಳ ಸೆಳೆಯುವ ನೋಟ ಹಿಂದೂ ಕ್ರೈಸ್ತ ಮುಸಲ್ಮಾನ ಪಾರಸಿಕ ಜೈನ ಜ್ಞಾನ ಜಗತ್ತನ ಹೋಲುವ ದೊರೆಗಳ ಧಾಮ ಭಾರತ ವೈದಿಕರ ರಾಮ ಕನ್ನಡ ನುಡಿ ಕುಣಿದಾಡುವ ದೇಹ ಕನ್ನಡ ತಾಯಿಯ ಮಕ್ಕಳ ದೇಹ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ.
Please take a seat. I now invite our esteemed principal, Dr. M. Sanikok sir, to deliver the inaugural address.
Our beloved principal of Dental College, Dr. Praveen Kudwa, Vice Principal, Dr. Prabhakar, other dignitaries on the dais, organized secretary Nandini, and all the professors and heads of the department of various departments from Siddhartha Medical College, as well as Siddhartha Institute of Medical Sciences, and other Siddhanganya Medical College. Okay, we are very glad to see all the wonderful students here, because I am so happy all sitting here and to organize this AdCom. It is a really wonderful selection of the topics are there, and I was going through the topics. Really, they will be very useful in your day-to-day life. and your moderators definitely will guide you in doing all this, and especially this attitude, etiquettes, and communication. Very important part of any of the medical or nursing students, anybody. Recently, when Dr. R.P. Pai was there, when we were talking about these things, how the ancient teachers used to teach, how they exactly, because we remember our teachers teaching to us, and also remember in between the students how they are being taught and how they are mentored. Because the mentorship program is also very important, that takes you in a big way. And apart from that, the NMC has made very much compulsory since 6 years, this EdCom. And of course, certain number of classes are very much reserved, and 80% of attendance is a must. In spite of all these things, some students are not getting trained to that level. That is the irony of, but earlier days it was not like that. Earlier days, the way our teachers used to impress, I am definitely trying to tell that we are not in a position to impress the students as much as our teachers used to impress us. We always used to remember still today, I remember some great teachers teaching. Early morning today, I was remembering of Dr. Balakrishna, another one, Professor Girigowda, and Dr. N.K. Channappa, especially in our Caves Hubli days. They have influenced in a greater ways to us. But now, of course, as the days are changing, and also the digital, this one is more now, and online teaching, or maybe you are more impressed with the way the teaching modules are given in your AdCom, this, and of course, you are in the next stage now. Our stage was we never knew what is computer, we never knew what is modern system of, but now the modern trends of teaching, learning, evaluation methodologies have changed your outlook towards the examination system, outlook towards the management of the patients. So much has happened. Of course, you are also right. It is not that I don't want to say only my teachers were good. Okay, your teachers are also guiding you in a better fashion, and also they are trying to mold you in a different this one modalities, different ways of teaching, learning, evaluation methods, and definitely you need to see to that they are all inculcated in your education, because ultimately the this effective communication, effective, these are definitely useful when we are going to see that, when we are going to see the patient management is concerned. Because during patient management, how much we should be, the way they see you, they should respect you as a doctor who has come to heal, come to support, come to give all that medications, moral support, this counseling. These all things definitely effective communication. These all things definitely will take in a big way for any of the doctor. Because when I was talking the other day also, I told almost the patients coming to the hospital are having more of psychosomatic diseases. The way you talk, the way you counsel, the way you listen to them, and that is almost 70% of the disease. Another 30% is depending upon the what all the organic behavior is. This one are there inside. All you need to attend. Some medications are required. Some maybe surgeries are required. Some modification in the lifestyles are required. So many things are required. Ultimately, those things can be convinced only by effective communication, effective counseling, and effective way of dealing with the patient care. Those things definitely should come. Okay, all, because whether it is a nursing student, or whether it is a medical student, or whether you are a dental student, whoever it is, try to talk to the patients, take them into confidence, go to their level and talk. That takes in a big way for the patient care. Okay, because this patient care, we have seen 90% of patients, they come for your, means just to see what is wrong with them. If there is nothing wrong in them, they will be more happy to go back and to start the rest of the works what they intend to do. These are very important, and of course, you are all eagerly waiting for all your. I don't want to talk too much on this, and your teachers are there, and mentors are there, and of course, from the various medical colleges, and even I know Dr. Sudha. She is also one of the effective communicator, and she is now gone. Earlier, she was in teaching. Now I think you are in now industry. Okay, that industry relationship is very, very important, because that is the one. All these days, only teaching, learning, and all these things, then go to industry. But it is not like that. Now, you in the initial days only, you should have the industry exposure. The industry exposure has to be there, because ultimately you will have to earn our bread and butter at the same time while serving the patients. We need to earn the bread and butter, and how best way we can serve the public with the help of our profession. That is also very important, and we need to respect the profession, and at the same time we should see to that we are gaining the knowledge, and we are becoming the better citizens of India, better citizens, and also the people should recognize you have come from Siddhartha Medical College, or Siddhartha Institute of Medical College, or Siddhartha Nursing College. Like that, they should be able to recognize you in that better manner. Okay, I congratulate Dr. Nandini for having conducting this, especially student-centric programs. Really, our Chancellor, G. Parmeshwara sir, he is very much for the student-centric programs. See how fine, really, it is looking so beautiful to me, because when we conduct the other programs, I don't see this much of a discipline. I'm able to see very good discipline, which has been student-centric should be there, and you should be the leaders. Okay, and you are the ultimately, by way of your behavior, we should be impressed, and college should feel proud of you. Okay, really a program has been organized. I congratulate once again, and I thank the organizers for having given an opportunity to deliver the inaugural address. Thank you, all.
Thank you, sir, for your inspiring words. I now invite our Honorable Vice Principal, Dr. Prabhakar GN, to deliver a few words.
All students have to become the leaders, right? That is ultimately the message which can be given by Dr. Prabhakar, because I congratulate him for having received the national level, the leadership award from the Indian Medical Association, which is one of the highest in India. Okay? And I am sure you will definitely inspire all of us.
Thank you, sir. Good morning, everyone. Respected leaders on the dais, and my dear colleagues and dear students. In fact, first of all, I should congratulate Dr. Nandini for conducting this wonderful CME. The topic she has chosen was really good. And when I saw the invitation, I was a little confused and I kept quiet. I didn't ask. But yesterday evening, I received a call from Karnataka Medical Council. Sir, you are conducting in your college, you are conducting some Ayush CME. No, it is a allopathy only. No, sir, I am seeing all the wordings here. Actually, our students, they coined all Sanskrit words, so they are confused that it is Ayush topics, but actually it's a Sanskrit thing. And then the speakers were not doctors. So again, the question came. So they are not even doctors. Yes, sir, it is a student centric and it's the students they are giving this thing. So they convinced and immediately they apologized. Okay, we'll give the 8 points. And really, it's good thing, but only thing, we have to communicate properly to the Karnataka Medical Council. Anyway, so the outcome, as sir said already, has talked, the few, remembering the old doctors. The old doctors, some of the doctors who are practicing, they used to see nearly 200 to 300 patients in a day. And they used to communicate in such a way that they used to know the patient, not only the patient's relatives also. So when the patient comes, you will not ask the disease first. How is your son? How is your father? I will, like that they used to ask. And a very good trust was there between the doctor and a patient. Gradually, the trust, there is a break, there is a gap in the patient and the doctor. And now we are not even asking the patient regarding the history and all, we directly see the X-ray, not X-ray, MRI, CT scan like that. Okay, so we are treating the investigations, not the patient. So that is the, see actually nearly 70% of the patient doesn't require treatment. Okay, so how you communicate to them, so that itself is enough. Okay, so that is the reason why the National Medical Council has introduced this ADCOM. So ADCOM, if there is no proper communication, you might have seen the youngsters who are working in the casualties and critical areas where the patient dies, so usually they are vulnerable for all the assaults. Okay, so you might have seen recently, as also last week, one doctor was almost, he was pulled out and he was, hit by so many, even the politicians also have known. So like that, these things happen probably because of the lack of communication or communication is not in a good way. So for communication, you need the language and also the attitude. So attitude is also very important. How you communicate is also important. Because you have to respect the patient. So if you don't respect the patient, then the patient attenders think in other ways. Okay, so many things are involved. So nowadays, even in your exams, you are not bothered about your diagnosis, you are not bothered about your treatment. It is how you communicate or how you behave with the patient that is more important. That's why whenever we see how you take estimates, whether you have treated the patient or not, so from there it will start. Your marks will start from there. Not for your diagnosis, not for your treatment at all. Okay? Because tomorrow, after becoming an Indian medical graduate, you are going to face the public. Okay? So for that, you have to be a good doctor. So In that, the AdCom is one of the important component. So now it is AdCom, whether it is a theory or practicals, all the components they are introducing this AdCom related questions and AdCom related assessments are there. So I think the Department of Pharmacology has taken a good topic and the present situation which requires this type of assessment. And once again, I thank the organizers for giving me an opportunity. Thank you.
So before we break for tea, I want all the pharmacologists, our department, Dr. Manjunath sir, Swami sir, and everybody to come today so that we can have one photo together. Please, from Siddhartha Medical College, Siddhartha Medical, Sridevi Medical College, all the pharmacologists, please. We can have a photo group photo here. No, we'll have because dignitaries will be there, so we won't have. So before we break for tea, please for a photo session. And thank you so much, sir. Actually, Kushal came up with all the Sanskrit words. Sir, sir, we want to have a group photo. Manjunath sir, income please, sir. Manjunath sir, please. So Kushal was very enthusiastic Sanskrit word anta. First time gottaಯ್ತಿದೆ the college alle CME ಆಗ್ತಿದೆ ಅಂತ. ದೇವರೇ ಕಾಪಾಡಪ್ಪ ಅಂತ. Then only I sensed okay. But somewhere ನನಗೆ ಪ್ರಭಾಕರ್ ಸರ್ ಇದ್ದಾರೆ ಕಾಪಾಡ್ತಾರೆ ಅಂತ. ಪ್ರಭಾಕರ್ ಸರ್ ಅಲ್ಲಿ ಕಾಪಾಡಿದ್ದು. So thank you so much for that sir because KMC ಅಪ್ಲೈ ಮಾಡಿದಾಗ ಎಲ್ಲ ಸಂಸ್ಕೃತ ನನಗೆ ಗೊತ್ತಿತ್ತು ಒಂದು ಆಗುತ್ತೆ ಅಂತ. But with all that is how Prabhakar sir partner in time of friend in crime whatever it is okay. He is there whenever your real problem no sir is there okay. That is the beauty of Prabhakar sir. Thank you so much sir. Thank you so much.
Ready, sir?
Organizers, please come. Come here. Can stand and few of you can stand on either side and
Right.
few of you can sit
Come,
on
come,
the
come.
side.
Right,
Yeah.
right, good, 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 nice, nice.
Cover, no?
Right.
Few of you can come and stand here.
Come.
Stand over.
If PGs, please come now. Pharmacology, where is it? Come on, pharmacology. Come, be back in the- Where are others?
Please stand.
Photographer. Ready?
Nyaya, healthcare as a right, not a privilege. I invite our next moderator, Dr. Naveen Kumar Sir, Professor, Department of Pharmacology, Sri Siddhartha Medical College, and our speaker, Kusumita B. Could we have a round of applause?
Good morning to respected teachers and my dear friends. I am Kusmita B, a second year MBBS student from SSMC Tumkur, here today to speak on the topic healthcare as a right, not a privilege. Before we dive into this topic, let us first understand what healthcare is. Healthcare is an organization which is designed for prevention, diagnosis, and treatment of physical and mental illness. The World Health Organization defines health as a complete state of physical, mental, and social well-being. Health is a very precious asset to every single person, and healthcare is considered to be the cornerstone of society's well-being. An healthy population is the backbone of nation's economic growth. This brings us to an important question today. If health is the foundation of all our lives, shouldn't the access to healthcare be guaranteed to every single individual? The answer becomes clearer when we look through the framework of human rights. A human right is a basic freedom or entitlement that belongs to every individual simply because they are human. They are not bought or guaranteed based on wealth or social status. Characteristics of a human health. It is universal. A human health belongs to every single individual, irrespective of age, gender, caste, religion, or socioeconomic status. A human right is inalienable. It means it is inherited from birth and remains with them throughout their life. A human right is equal and non-discriminatory. Every single person deserves equal respect, dignity, and access to healthcare, irrespective of any social barriers. They are interdependent. Of other rights. And I believe healthcare as a right is the foundation of all other human rights, like right to life, right to access healthcare, right to equality and non-discrimination, right to information, right to privacy and confidentiality, right to dignity and respect, right to informed consent, right to safe and quality of care, right to food, and right to safe drinking water. The World Health Organization formally recognized healthcare as a right in 1946 and officially introduced the AAAQ framework in 2000. The AAAQ framework consists of availability, accessibility, acceptability, and quality. Availability. Healthcare facilities, services, healthcare professionals, medicines, and vaccines must exist in sufficient quantity to meet the needs of the population. Unavailability of essential healthcare needs shouldn't be the reason for the death of a patient. Accessibility. Healthcare services must be physically reachable, financially affordable, and accessible to everyone without any discrimination. The patient's locality should not determine his or her chance of survival. Acceptability. Healthcare facilities and treatment must respect medical ethics, be culturally appropriate and sensitive to gender and life cycle requirements. Quality. Healthcare services must be scientifically sound, evidence based, safe, effective, and continuously improved. High quality care not only improves the health outcome, but it also enhances the patient's trust and confidence in the healthcare system. But today, we have reached a point where we are letting our greed erode our humanity and deprive people of their basic human rights. For instance, a patient named Lakshmi Narayan, aged 42, was admitted to the hospital after he was diagnosed with COVID. He remained hospitalized for 2 weeks and sadly, he passed away. And his medical bills came up to be around 3 lakhs, which his family members couldn't afford. The hospital refused to give his dead body back to his family members. According to Section 340 of Indian Penal Code,
It is a punishable offense for hospitals to keep the dead body hostage just to force payment from their family members, even if the medical bills are undue. That's not it. The true tragedy lies when people are denied timely treatment just because they cannot afford private care. Some private care hospitals have even gone to an extent of refusing the Ayushman Bharat beneficiary. In Bijnor, Uttar Pradesh, 7 doctors forced the patient to pay rupees 35,000 for a surgery even though he had an Ayushman Bharat beneficiary. Following the RTI data which was revealed, 87 private care hospitals in Maharashtra are still refusing the Ayushman Bharat beneficiaries. We are letting our 4 pillars of medical ethics be compromised, and we are letting our greed overshadow compassion. The 4 pillars of medical ethics consist of autonomy, beneficence, non-beneficence, and justice. Autonomy is the right that the patient has to make his or her own decision regarding treatment. Beneficence is that any action taken by a healthcare professional should be in the best interest of the patient. Non-maleficence is to do no harm. Treatments should help rather cause any harm to the patient. Justice emphasizes on fairness and equality. I believe that if the question arises if the healthcare should be a privilege or a right, justice reminds us that treatment should never depend on wealth or social status. How do we build a better healthcare system for all? To ensure that healthcare is a fundamental right, it requires a multifaceted approach which involves government, healthcare institutions, professionals, and communities. We need to begin by strengthening the primary healthcare centers. Primary, primary healthcare centers are the backbone of the healthcare system. By strengthening these primary healthcare centers, we can make early diagnosis, treatment, and prevent diseases. Digital innovation. Technology has the potential to bridge gaps in the healthcare system. Digital records. Telemedicine helps, helps healthcare system be connected and makes it more efficient. Value-based care. Value-based care emphasizes on respect, dignity, safety, quality, and patient satisfaction, making sure that healthcare provides the best care as it can to each and every one of them. Equitable financing. No individual should be denied timely treatment because of medical constraints. Preventive and wellness approach. As a healthcare professional, our duty is not only to treat diseases but also to prevent them. I believe that the solution does not only lie in strengthening the state health policies, but it also lies in the transformation of a mindset. Our duty extends beyond writing prescriptions. We must treat every patient equally, communicate honestly, respect dignity, practice compassion, and advocate for equitable health care. The government must strengthen the public health system, the hospitals must remain accountable, and we, as healthcare professionals, it is our right to treat everyone equally. I would like to conclude with 2 timeless sayings, Dharmo Rakshati Rakshita, which means Dharma protects those who protects it. And it is our right to treat everyone equally. Sarve Bhavantu Sukhinaha, Sarve Santu Niramaya. May all be happy, may all be free from illness. Let this just not be a saying, but become a promise. Thank you.
Thank you, Kusumita. I now request our moderator, Dr. Navin Kumar Sir, to present token of appreciation to Kusumita and also share his reviews on the presentation.
So some of the developed countries have schemes of free treatment. So this is the era of free gifts for the public. So I think one or the other day, even in India, they will provide treatment free of cost. That is my hope. Second thing is there are some disadvantages. Like for some procedure, you have to wait for 3 to 6 months in developed countries because of short of doctors and short of other things. Such things should not happen. They can access to private and as well as government. And if it is given at a free of cost, maybe for the tax, they charge more tax for that. So, but the treatment is free for everybody. That should have been implemented. and there are some pros and cons. So, as she said, she would have explained that last survey Santo Niramaya.
Sarve Bhavantu Sukhinah, Sarve Santu Niramaya. May all be happy, may all be free from illness. Let this just not be a saying, but become a promise.
Everybody should be free from problems, health problems, and other difficulties in the life.
I would like to invite Dr. Manjunath sir to present the memento to Dr. Naveen Kumar sir. Next, we will have our guest lecture. I would like to call up our moderator, Dr. Nandini ma'am, to kindly introduce our speaker for the day, Dr. Sudha ma'am.
Hello everyone. So the next interactive session is Lady of the Day, and Dr. Sudha ma'am, very friendly. Okay, so here goes Chikitsa Niti, the ethical choices in modern medical education. So ethics is not taught in classroom alone. It is practiced in clinics, wards, and every difficult decision we make as a future healthcare professionals. It's my honor to introduce our distinguished speaker, Dr. Sudha MJ. She has pursued her MBBS, MD, DNB Pharmacology, PG Diploma in Bioethics, ACME. She is a medical and a regulatory advisor at Heal Isomed, Bangalore, with over 20 years of experience spanning academia, pharmaceutical governance, and clinical research. She has held key positions in academia, industry, and global medical affairs, including serving as global medical advisor at Novo Nordisk global headquarters, where she contributed to regulatory strategies, clinical evidence generation, and medical affairs across international markets. She is a national level trainer in Indian medical device regulations, DMR 2017, good clinical practice and research ethics, and actively mentors medtech and health tech startups. She has authored more than 40 national and international scientific publications and has made significant contributions to medical education, clinical research, and regulatory science. Ma'am has contributed immensely to medical education and bioethics, making her the perfect guide for today's theme. I request Dr. Sudha MJ to kindly deliver the interactive session. Welcome you, ma'am. Thank you so much for being with us.
Thank you so much, Dr. Nandini, for those humble words. A very good morning to all of you. I'm speaking in English for those who don't speak Kannada here. Good morning. Okay. Thank you so much. First of all, I would like to start by thanking the pharmacology department, Dr. Nandini and her team, and the entire institution. I'm happy and honored to be here to talk to you all about Chikitsa Niti. Anybody knows what it means? Because it's a Sanskrit word. It's not Kannada, it's not Hindi. What is Chikitsa Niti? What does Niti mean to you? All of us have heard about Niti Pata, no? Nobody has heard about Niti. Can we have the lights on? They're all going to sleep. Sorry. Can you check my presentation on? I'll get down. Okay, this session is only for all of you who want to be here. Those of you who don't want to be here are free to leave or free to sleep. I'm not going to disturb you, but if you're in the hall, I'll consider you're with me for the next 30 minutes. So who are all with me? I want a show of hands. I want a show of hands. Who are all with me? Give a big round of applause for each of you. For each of you. And thank you for singing the Nada Geeta. I'm very happy. Yes, I don't know your name, sir. Yes, yes, yourself. I was very happy to see. There were four of, yeah, those two girls as well. They were singing. I was very happy and proud because this is not something, not to be proud of. You don't have to put your heads down and, stand there. You can sing along if you know. If you don't know, it's all right. You'll learn eventually. Okay? So what is ethics? We're talking so much about Satvrutta, the path, the good path, right? Satvrutta means good path. What is ethics basically? What does it mean for you? The next 30-40 minutes, you're going to talk to me. Okay, if not, you are free to leave the hall. Nobody is making it mandatory. Attendance session is over. Attendance session is over. So you can leave if you want. No compulsions. My sessions are only for those who want to stay. Is that okay? I want a response. You guys don't speak English? I speak Kannada, English, Hindi, Malayalam, somewhat Malayalam. Okay, I can speak in these languages fluently. If any other language, if you are from some other language other than this, Telugu also I will speak. No worries. You have to tell me now before we start the session. This is not something to be taught. I never believe in teaching. It's always teaching and learning. Do you agree with me? There's always something you give and you receive in return. Yes? Yes or no? And all of those, give me a show of hands. How many medical students are here, MBBS students? Thank you so much. Your partners or your healthcare team is sitting right here. Please give them a big round of applause. Your connection, your networking, your learning starts here in this hall with them. Okay? And for those of you here, you have to learn with them. Okay? Have you heard the recent speech from Dr. Devi Shetty? How many of you have seen Dr. Devi Shetty's speech about nursing candidates recently? Has anybody heard Dr. Devi Shetty's talk? What did he say? About nursing candidates. He has invited in his institution nursing candidates to become CEO for the CEO role. They are no less. Healthcare is a teamwork. One of the speakers before me has spoken about it, right? It is a teamwork. It is never an individual task. You alone are nothing in a healthcare setting. And whoever is sitting next to you today is going to become the directors, the consultants, the clinicians of tomorrow. In first MBBS, second MBBS, I used to laugh with these friends of mine, especially those who used to sit in the end. Those days, we had to move from one hall to the other to attend lectures. Okay? When we were attending lectures, we used to run and catch seats. Do you all do that? Yes? And you know why I used to run? Because if you go late, what happens? If you go late, what happens? You'll have to sit in the first row. How many of you do that? Run to the session so that you don't have to sit in the first row. Yeah? There are some. I'm happy. There are students like me. Okay? Doesn't matter where you sit, how you study, what you study, with who you study. These are the people whom you'll be working with more than subject content per se. There is more to life. Okay? I think Dr. Nandini with her team is trying to tell you all about that, the path that you're going to take, right? So that is what today's session is all about. And if you don't talk to me right now, I'll have to stop the session and go sit. If you guys don't want, I can stop here now. How many of you want the session to continue? Only Dr. Nandini wants the session. Huh? Okay. Okay. I see a few hands. No problem. I can continue comfortably. Okay. Coming to chikitsa needing, it is nothing but the clinical choices that the doctor has to make. Okay. When I made this presentation, it was only for doctors. But now I also see a lot of nursing students. They are also the part of team. It is equally applicable to you because you hold more responsibility. A doctor prescribes, they leave. Who comes in the care delivery later? You guys are equally or more important, right? So for those of us who prescribe and leave, it's not only so much. There is more to it, right? Can anybody tell me what ethics mean to you? We talk so much about ethics, ethical path, bioethics. The speakers before me, Kusmita mentioned 4 pillars of bioethics, right? What are they? Autonomy, beneficence, non-maleficence, then justice. So can you have all these 4 principles without having a clash between each of them? Are they so separate? They're 4 different pillars? Yeah? Is it so? I want responses. Otherwise, you're not here in the hall. I can as well talk to you virtually from somewhere, right? I'm here physically. I want you all to be physically here. At any point of time, do you think these 4 principles clash? Or are they all very separate? You know, autonomy can be discussed separately. Beneficence can be discussed separately. Non-maleficence can be discussed separately. Can it be done that way? Yes or no? Yes, sir. Yes, sir. Can we? How many say yes? Again, show of hands. Yes, sir. Oh, he's talking on the phone and saying yes to me. Huh? Okay, the question is, all the 4 pillars Kusumita showed about bioethics, autonomy, beneficence, non-maleficence, and justice, can they be discussed individually or can there be clashes between these? Do you understand these terms? Do you actually understand these terms? Yeah. Now tell me, can they be treated separately? Should it be a part as a whole? As a whole. Then if there is a clash between autonomy and justice, which one will be more important? Making a medical decision, patient right or justice? Autonomy wins. Thank you. Sit down. So autonomy wins. So you will not always have a single ethical dilemma. When ethical dilemmas happen, there can be more than one principle which clashes. So you need to make instant decisions as to what is important, how, based on certain characteristics that are described. So all the speakers who came before me have made things easier for me. I like the name Dhan Win. He has Dhan and Win both in his name. So today's my session is all about what is bioethics, why does ethics matter, medicine society law and learning objectives. My PowerPoint presentation, I have prepared some 150 slides. How many of you will be with me for the 150 slides? She's staring at me. Oh my God, that was a scary stare. Thank you. That is what I was expecting. It's not so. My PowerPoint doesn't power me. I power it. So ignore that if you want. It doesn't really matter. Okay? It is totally AI assisted. I've developed it just for making sure that I don't go off track and my time is managed. But that will not power me. I power the PowerPoint. Okay? So these are the things which we are going to talk about. 10 minutes, 15 minutes, enough, right? So next 15 minutes, we're going to talk about this. What is ethics? Who can tell me what ethics means to you? Can anybody tell me what ethics mean to you? I'd really love to hear from you. I didn't hear your voice. Yes. Introduce yourself and tell me, please. Speak up. You don't need a mic. Your voice is nice though. Your name and what ethics means to you. Anything that comes to your mind when I say ethics. Not very complicated. Okay. You know law? Laws? What does law mean to you? What does it mean to you? What is a law? What does it mean to you? It's okay. Sit down. The person behind, sit down. Oh, everybody is on the phone. Ask him, please. What does ethics mean to you? Music was good? Was the music good? I'm talking about ethics in law. Can you tell me what it means to you? Please take the mic. What ethics means to you? What interactive session? Man, none of your students, all of them are sleeping with me. Sorry. Anyone wants to make an effort of telling? See, you all will remember Dhanvin. After 10 years also you'll remember Dhanvin. And that happens. He may not remember all of you. Seeing here for the first time coming on the stage, he'll be so scared. He doesn't remember or recall a single face. But you will remember him. Take every opportunity. It is important. Doctor is not just a doctor. Okay? You are going to be a leader, like Dr. Sanikar was telling. So you have to choose and pick every single opportunity that is presented to you. Don't ignore. Say what comes to your mind. We are not here to, point out and say this was, you shouldn't have spoken like that. No. But do it in a nice way. Right? What does law mean to you? Yes, you sir. The action. Sorry, I don't know the names. In my class, I would have called out the names, but unfortunately, yes. What does law mean to you generally? Sorry? Which? Okay, thank you. What does ethics mean to you? Excellent. Yes. What does morality mean? What does it mean to you basically? Because we're talking so much about the path that we need to take, right? So we're going to talk about ethics, bioethics, and what it means to you. I would like to know before I start off with my lecture. It gets boring after a while, right? Most lectures get boring. So, morality. What is morality? Do you behave morally obligated most of it? It's an obligation. Is it an obligation or it comes from within and you want to follow that path? Thank you. Please be seated. See, law is something that is laid down by an external agency. It comes from outside. You have to follow law of the land, right? We have to follow the law of the land. And in ethics, it is more of what comes from within. Whether anyone is seeing me or not, I'm still not doing my assignment or studying for my next exam there. If you're in my lecture, you're listening to my lecture. That is what ethics is or professionalism is. Okay? Whether someone notices or doesn't notice what you do, how you behave. That is what eventually makes you who you are. Every single day's action. It is a character building. Being Indians, most of us, we have this innately, we are brought up in a way where we are taught this from very young age, right? It is culturally inculcated in us. Certain habits are inculcated in us. We like the lamb. We take off the shoe. Not necessarily always. We respect trees and plants, right? So all this is inherently within us. So when we take this and apply this science, when we apply to other aspects, when you apply it to sociology or medicine or any aspect in biological systems, it becomes bioethics. If you apply it for clinical medicine, it becomes clinical ethics. So Chikitsa Niti is nothing but clinical ethics, right? So that's what we are talking about today. And Kusumita has made my life easier by talking about the 4 pillars. And today's session, how did this all come up? Why do we have to follow so much of code of ethics? Have you heard of NMC Code of Ethics? All the medical students here, have you heard of NMC Medical Code of Ethics? Anybody has heard? That is what we all need to follow. Can you, as a doctor, advertise yourself and solicit patients? Can you do that? You see a lot of these health coaches, no? They put up this before and after pictures, beautiful. Before they are 200 kgs or 150 kgs, and after the treatment of 1 month, they'll show 50 kgs, someone beautiful, right? So we as doctors, can we do that? Why? Why not? Why not? We treat better, right? We have better therapies, better medication, better management of the disease, because we have a set of rules, or we have to follow a code of ethics. Okay, this is called Code of Medical Ethics, which is laid down by our regulatory body, which is National Medical Council, which was Medical Council of India previously. So how did this evolve? How did we actually get here? Whatever is written in current medical code of ethics to arrive here, this is the history. This is how it evolved. From initial stages, it started with Hippocratic Oath. See, whenever there is a law and there is an amendment to it, do you understand law and its amendments? Yes or no? Yes. When do you amend it? When do you upgrade it? What could be the reasons when you amend it? Will there be any reason, or just like that somebody will change it? When there is a need, requirement, and that is accepted by the people who need to follow that, if a majority of the set of people feel okay, this is acceptable, they will change the whole law or add an amendment to it. So that is how each of these reports came in. Okay, this is the evolution of bioethics. It started with initially Hippocratic Oath, then came the Nuremberg Code. I'm not going into the details of it because you guys are not interacting with me. If you interact with me, you will understand each one of this, but doesn't look like you are interested. So I'll skip through that and go. I'll just tell you, these are all the landmark or key documents or incidents that have happened because of which these documents were developed. Okay, this is the foundation of ethics. Based on this, National Medical Council has Medical Code of Ethics, which you all need to follow. So, as I mentioned, my slides are just slides for you to see. Majority is in the conversation. The content is in the conversation. So, you know how new drug is developed. All of you are in pharmacology, right? So, how anybody can tell me how a new drug is developed? How a drug is developed, basically. Anybody can tell me. I think now the faculty have to take over and tell how the drug will be developed. How is the drug developed? You identify a chemical molecule. Yeah. Then you run through the animal studies or in silico models. Then, if the data is appropriate, if the safety and efficacy is okay, if it is safe to use, then clinical trials will be done. This takes years of development, and once it is safe to use in humans, you will continue and go on to give it to the patient. So why am I talking about this in the clinical ethics session? Because you as doctors, you as nurses will be a part of clinical research, that is drug development process. When these drugs, experimental molecules, are being tested in human beings, you all will be there to ensure that the patient's right safety well-being is appreciated or taken care of. Okay, so that is where your ethics comes into play. That is called research ethics. Okay, I've still not got to the clinical ethics. Now, every new drug when we develop, whenever there is a, even if it has got marketing authorization and it is available in the market, if there is a change in the dosage form, in the formulation, okay, in the disease population, the population in which, for the indication for which it was provided, okay, if there is any change in any of those, you have to rerun all these clinical trial phases, okay, and that, to arrive at that stage all these events have happened from 1937 to 2026. There are a lot of events that have happened, which has led to the current drug development process. Okay, so the regulatory body for drug development in India is Central Drug Standard Control Organization. Okay, and they give out the guidelines or regulations. But today's session is not about SEDESCO or rules that we are talking. Today's session is about research ethics and clinical ethics, right? So you all as doctors and nurses should know what your role is and how well you can safeguard the right safety well-being of the patient or the participant in those studies. So all the four parameters or pillars that she mentioned, can I ask her, please, to tell me the four pillars of, just tell me the four pillars which Kusumita mentioned. Can you please repeat that? Pillars of bioethics. Four pillars of bioethics. We repeated so many times now. Yes, louder. Autonomy. Beneficence. Non-beneficence. And justice. Okay, thank you. Please be seated. So these are all the things that we are going to focus on in this session. You need to understand these are the landmark issues or events that happened. Each time an event happened, there was a new regulation or law added or amended, or a new guideline that came into existence. Okay. So, what is ethics finally? It is not only about what the law says, it is about a lot of things which is there, like trust, compassion, empathy, clinical reason. This is basically all these characteristics, your individual personal identity included, is what constitutes the clinical ethics. If you are following this, if you are abiding by this, you don't have to worry about legal issues at all, because documentation is also an important aspect of following or being compliant with clinical ethics. And now, why this becomes important? Is it important to follow ethics? Should we all be ethical in the first place? And can you always follow rules? We are all human. Error is human, right? So, what happens when you do not follow this, or when there is no opportunity, or something wrong always happens, right? It's not like you can always be right. It can happen. So, what comes to your benefit, or what saves you out of your issues or legal problems, hassles, or how to put it, how to defend yourself in those situations is your documentation comes into play. If you have done everything in your capacity for the benefit of patient, in the law there is an opportunity or option for you to explain yourself. So when we say medical negligence, it is a total different area. Unless until proven there is negligence which happened, you are not to be punished. Okay, there are a lot of laws around this. Fine. So bioethics in clinical practice, basically in consent, confidentiality, and the truth telling, in many of the other things. I have one of your colleagues will come up and talk about end of life care after the session, I guess. So recently, the new ones, artificial intelligence, how you should incorporate all this in your daily practice and still stay safe is what is clinical ethics all about. Okay. Now, how many of you in the hall want to go into medicine, internal medicine? Show of hands. Post-graduation, medicine. Any doctors in the house who wants to go into medicine? Nobody wants to do medicine. None of you. Not a single person. Oh, finally, one girl. Only one person. Only one. All of you want to become what? Nobody wants to do post-graduation. All want to. Everyone is surgeon, then there won't be anesthetist and there won't be other people. Please, thank you. Please give her a big round of applause. I have one, at least, general medicine, internal medicine. See, remember, what's your name? Grishma. Thank you. So remember Rishma, okay? Tomorrow she may be getting the award here, right? So today's session, I want one more person who want to do medicine. Nobody wants to do medicine. None. Literally none. Then I will pick the pharmacology PC to, just have a duel with her because I have two case scenarios. I have no option but to pick one of you, Please pass the mic to Rishma and one of them. Okay? I'll give you two case scenarios here. I want you to tell me how you will make the clinical decision. Keeping in mind, what are the four principles that we are talking about today? Call it. What are the four principles we are talking today? Please. You are free to leave. There is no harm. You guys can go out and have fun. No worries. I don't have any objection to it. You're in my lecture, you have to listen. Sorry. What are the four principles? Just repeat the four principles for me, please. When you go out of the hall, no, you will remember at least these four. I want you to do that. Thank you. Did you get the mic, Rishma? Please stand up. You give the mic to one of these guys. Pharmac PCs, right? Yeah. Can you introduce your name? One of you who wants to speak. Yeah. Sorry? Yeah. Priyanka. Nice. Thank you. Please help me out here. Huh? Mic could you? Okay, now, see, we have two case scenarios. Now, I want to understand if you were a doctor or if you were a nurse in this scenario, how would you pick, okay, your treatment? Who will you pick? There's one last single ICU bed. Okay, this is in the past. During the second wave of COVID, a tertiary care teaching hospital has only one hospital ICU bed. Okay, with one ventilator available. Within 2 minutes, two critically ill patients walk into the hospital. Right? So, who should receive the ICU bed and why? Both of you have to tell me your choice and you have to tell me why. These are the patient characteristics. Okay? Rishma, who do you pick? You go through it for a minute. Who will you pick? Priyanka, you can pick your patient too.
The 32-year-old patient.
Okay, patient A. Priyanka has picked patient A. Rishma, you can also pick patient A, no problem.
Even I will.
You also pick patient A. Anybody for patient B? Anybody for patient B? Anyone? Nobody to contest me today. Anybody wants to pick patient B here? No? No patient B? No? Okay. Oh, in this year, thank you for saving my life. Oh God. Finally, yes. You pick patient B, right? Why would you say patient B?
The patient is diabetic and
There's only one ICU hospital bed. So you're picking that patient over somebody who is 32 years, who has SPOT is 76, so estimated survival rate of 80 to 85 to treat. Why? Who has better survival chances here? But you picked patient B. Why?
because he's also has chance 20 to 30% chance.
Oh, maybe he was your professor. You like him so much. No, no harm in it. No harm in it. Hey, you all, if I come tomorrow, you have to take care of me first. Huh? Is that how you guys will decide? Is that how you will decide? Dr. Sudha was my professor. I'm not the Sudha which Dhanvin was describing in his case scenario, but I'm Dr. Sudha. If I come tomorrow, is that how you'll pick? Thank you for that response. Now, Priyanka, would you like to tell me why you picked patient A?
Yes, ma'am. First of all, the SpO2 is 76% compared to the patient B, it's 74%. And he has no comorbidities. His age is 32. And the estimated survival rate is also 80 to 85%. So he's higher chance of survival. So I would like to give.
But it is COVID, it's very unpredictable. Anybody can live. You picked him.
Yeah.
Okay. Okay, let's hear Reshma first before going something. Thanks, Priyanka. Reshma, do you have anything more to add?
No, ma'am. Higher chance of survival.
Similar. Okay, so what are the parameters you're considering here, Priyanka, to consider? What are the parameters?
His SPO2,
Okay,
no comorbs,
okay,
his age.
okay. So yeah, you mean younger patients have to be picked.
Not like that.
Older patients don't deserve a chance.
Because-
Whoever is 70 plus in the hall, please go. We're not picking you.
This, in-
No, it's okay. It's okay. Come on. You're right. You're right.
Yeah.
I'm just having this conversation so that they're all not sleeping. Yeah. That's right. You're right. Age has to be considered. Age is a factor to be considered. Very important. Age is important, right? Okay. What other parameters did you consider? She's a mother of a 3-year-old child. Does that count? Does that count? Is it important parameter? Should it be considered? So you'll let the poor professor die. Huh? Papa, he has taught hundreds and thousands of students and you'll let the poor professor die. Huh? Thanks, Rishma. So, Priyanka, if I change the scenario, okay? If I switch the prognosis percentage, patient B had a 90% chance of recovery and patient A only 20%. Okay? All that I'm switching is only the survival percentage. Will your answer change? No? No? How many say yes with me? None of you? What are the parameters? Oppa, finally I have one guy, half face. Okay, full one guy who say yes. Okay. What are the parameters that you consider when you're considering when you take accountability? You have 2 minutes to decide this. You don't have the whole day. Will it change? Will your decision change? Now some people are like, okay, I'm getting there. Clinical decision or clinical outcome is a key crucial aspect that you need to consider. You need to consider key outcomes. Okay. So yes, probably that would be one of the key. When you write your list of parameters to assess clinical outcomes comes on top of it. Okay. Then, would your answer change if patient A were a politician or patient B were a healthcare worker? Poor doctor and professor is dying, and a politician walks in. Who will you treat? Will you change your treatment? Priyanka is very ethical. Okay? She's proper, pakka. No, I'm going to save the person who deserves it the best, irrespective of their socioeconomic background. Thank you for that. If another ventilator became available after 30 minutes, how would you justify your initial decision? Okay, this is where your documentation comes in. Thanks, Priyanka. Thanks so much. So, this is where your documentation comes into play. Even though you're right, many a times, the outcome is unpredictable. You don't know who will survive. We are not God. We are just doctors. We'll do the best we can. For that, you have to have proper knowledge of the subject, proper understanding, ability to make clinical decision on spot at that time point. Okay, so for you to do that, you need to have in-depth knowledge, understanding of the scenario. You also have to have a complete patient background details. Okay, you should analyze and assess, and this decision should be free of all the other, you have to consider these medical considerations, ethical, legal as well. Legal. Tomorrow, you should not go to jail simply because you picked one over the other. What were your considerations to pick? You need to ask these questions. What is the diagnosis? What is the severity of illness? What is the expected benefit of the ICU care? What is the probability of survival? Are there reversible causes? Are there significant comorbidities? This was what was listed in the previous slide. Okay, if you consider, if you look back at this is exactly what was listed. Medical considerations. Then you have ethical considerations. Okay, whether a politician walks in or not, socio-economic, we are not looking down about politicians. Okay, we're still friendly with them. We want all the work done right. We want good governance, right? So we'll still treat them, but they will not get any additional benefit simply because of their position or power. Okay, So these are the things that you need to consider ethically, legally and professionally as well. You have some obligation towards the hospital as well. You as a doctor have considered everything. And Priyanka, one last question, okay? You have considered all the parameters, medically, ethically, you have accepted. You have chosen patient A, which is patient A, right? Yeah, patient A, correctly, okay? But your hospital management will come and say you're working as a consultant in a hospital X. And your hospital management will come and say that patient cannot afford. Okay? Then your ethical dilemma starts. What will you do? Will you still neglect, ignore, and go ahead and treat, or will you not treat? Or will you still allocate that ventilator? Because ventilator is not yours, it's the hospital management property. What will you do? Last question. Yes, but will you allocate or will you not allocate? Will you treat the patient there or will you not treat the patient? Patient is not affordable. They cannot pay the money. And it's not your hospital. And it's not the only patient you'll be treating. Hundreds and thousands of patients you'll be treating. How many of you are confused here? How many of you say, I'll go ahead and treat? No show of hands for that. Nobody is willing to treat this patient. They'll let both patient A and B die. Yes, we'll conclude. So, any response that comes to you? Thank you. This was called ethical dilemma. Thank you so much. This is where your understanding of these three parameters come into play. As a doctor, as a human being, she wants to treat the patient, but it is beyond her capacity. She cannot. So she'll discuss with the patient relatives. She'll discuss mindfully, meaningfully. She'll try to engage professionally with the management. She'll try to explain these are all the things that we need to take into consideration. You cannot deny the patient simply because of this reason. But despite that, if they say she's helpless, she cannot do anything more, she'll document the same in writing. She's safe. Patient, sorry for the patient, but that's all she can do. But if she owns the hospital, the scenario is very different. She can make the decision for herself. There's something called institutional policies, which we need to take into consideration. Okay, here is where your communication skills come into play. How well you can make the management or the hospital understand what is the requirement, because letting a patient die is not very good for the hospital either, right? So how can you do that really well? The communication comes into play. So attitude, ethics, communication, keeping in mind medical consideration, ethical consideration, legal and professional consideration, you will make the decision. So these are all this is called clinical decision framework. Please have a look at it. Take 10 seconds to understand what is on the slide now, because this is the key to every single decision you'll make for the rest of your lives. You may not face with this dilemma every single day, but I assure you, if not this, a different scenario, similar one will present to you wherever you practice, irrespective of your practice, irrespective of the question, okay? Your decision framework should rely on this. I'll end my talk with this. I have a lot of clinical case scenarios for autonomy as well. How many of you have watched the movie called Patch Adams? You don't watch movies, you don't talk, you don't study. What do you guys do actually? Reels also are good. Watch Patch Adams. Nobody has watched it. Not a single soul here. Oh my God. Have you read the book When Breath Becomes Air? You don't read novels? Oh my God. Sad state of affairs. Anyway, I'll end the session on a high note. Thank you for participating, whether forcibly or otherwise. Thank you for interacting with me. Even that was important because that shows how professional I am. I didn't yell at you. I didn't scold you. I didn't throw you out of the hall. I can do that. I have done that in the past. Okay, but that was my learning phase. Okay, today's session, I know that I cannot force feed you. Unless you want to understand, you want to be a part of it, I cannot force anything onto you. His autonomy today is limited, unfortunately. Okay, this is where dilemma occurs. Ethical dilemma happens to me. Should I force him to sit or ask him to leave? This is where the dilemma happens. Even in medical education, it is very important. Okay, thank you so much, sir. I'm nothing against you. So thank you all for your patient listening. Thank you for engaging with me. I had a good session. If you have any questions, I'm happy to answer. No questions only mean two things. Either you didn't understand anything, or you're happy with the session, or you want to end the session. Okay? Thank you so much.
Thank you so much, ma'am, for such an interactive and beautiful session. Now we would like to invite Dr. Lohit K. Sir, Professor and HOD, Department of Pharmacology, SSMC.
SSIMS in Research TB. To present the momentum.
Now the sound decides whether you like my session or not. Let me force things upon you. That's called coercion. Ethics, it is a very important term. You should not coerce the patient into any kind of treatment. Okay? Okay, a big round of applause to each one of you for sitting here since morning.
All the organizing members, please come for a photo. For our next session, I would like to call upon Dr. Sushma ma'am to introduce our speaker for the session, Dr. Subramaniam Katapura sir.
Good afternoon, everyone. Respected dignitaries of the dais and all my dear friends. In behalf of Department of Pharmacology, it's my privilege to introduce our beloved speaker, Dr. Subramania sir Katapura, and he is professor and head of the Department of Pediatric Surgery, Sri Siddhartha Medical College. As such, for this institute, it doesn't require any introduction for sir. We all know him since so many years. And with 14 years of experience in pediatric surgery, he has successfully managed wide spectrum of complex surgical conditions and including congenital birth defect in neonates, pediatric urological surgery, minimal invasive surgery and thoracic surgery, bronchoscopy, and solid tumors in children. His commitment and expertise have played a pivotal role in developing the Department of Pediatric Surgery at Sri Siddhartha Medical College. And Dr. Sir Subramanian sir has served as visiting associate professor at Cincinnati Children's Hospital, USA, and he had a clinical position in renowned NHS Institute in UK, and also he is a chair elect of the Karnataka State Character of Indian Association of Pediatric Surgery for the term 2026-27, and he has previously served as Honorable Secretary. Beyond his outstanding surgical accomplishment, Sir has impressively has international publications and scientific presentation and academic contribution. Above all, he is a passionate teacher who has consistently mentored undergraduate and postgraduate students with dedication and enthusiasm. His unique blend of clinical excellence, academic scholarship, and commitment to medical education makes him an ideal speaker for today's session Ethicon. I am sure we will all eager to benefit from his expertise and wisdom. It is now our honor and privilege to welcome Dr. Subramania sir to deliver his talk on Tattva Bodha, the insights on Ethicon. Sir, the stage is all yours. And I would welcome Dr. Swami sir as a moderator for this session.
Good afternoon, everybody. I'm Dr. Subramania. I'm a pediatric surgeon. I thank Ginny ma'am for giving me an opportunity. Before I start, I would like to tell the medical students one small joke. You know, Dasharatha, Kaikeyi, Dasharatha Kaikeyi, Rama's father. Now, Kaikeyi was the stepmother of Dasharatha. Kaikeyi came and asked Rama, Rama, what punishment did you give Dasharatha? Kaikeyi asked Dasharatha, what punishment did you give Rama? What did you do? Dasharatha said proudly, I threw him Vanavasa for 14 years. Then Kaikeyi said, Are yaar, you should have sent to MBBS. Post-graduation, super specialty, 14-15 years gone. Then learning skills, another 5-10 years. So that is the state of medicine as of now. Okay, that is what is medicine now. So even my son has joined the MBBS, so I feel, pity. It is not, no, it takes so many years to hone the skills and become, that is a pain. So now, before starting AdCom, the teaching system has changed dramatically. In the past, it was sage on stage. Now it is guide on site. We are facilitators. We are no more teachers. Okay, things have changed so much. So with that, I'm going to start my talk on AdCom. Oh, can I have the speaker? It is not coming. Can you hear this? Oh, yeah. Okay.
How's my son? You said he was He's a very literal man. That's the way I would take him. Oh, this guy again. That was the doctor. Looks like oh my God. Oh God. The tears are coming. The tears just are coming. Just to be clear, it looks like he's dead or he is dead. It just looks like he's dead. He's got like blue paint on or something. He's going to be fine. Doctor!
So this is one. See the the next video.
My name is Mary. How can I help you? I'm here to screen for cervical cancer. My sister had it done last week and said I should come in. I haven't had it done before. Okay. Well, before we talk more about what you need, it's important that you understand that everything we talk about is confidential. It will be documented in your chart, but it won't be shared. Okay? Okay. Yeah. Okay. It's great that you came in for the screening. Before we get to that, I'll need some information from you regarding your health history, particularly around your reproductive health. Is that okay? Of course. Okay. What's your age?
Okay. So you saw those two, videos. One was in the ICU, and another one was a counseling for cervical cancer screening program. Now, what was wrong in the first video? What stares at you? What was wrong? What did he do? Can anybody tell me? Was there any empathy? Did he give them some space? It was very rude. Second one was in a closed setup. So when I went to UK, a lot of people used to come with MCH and DM. They never used to pass in communication skills. That was a major, stumbling block for all our country people, graduates coming with lot of degrees, coming from PGIMs, fail in communication skills. 15-minute sessions, they used to fail miserably. You take it after 6 months, again fail. So we are taught, we are actually not taught how to talk to people. We don't know. We need to fine tune ourselves. People used to say, driving in India, if you can drive in India, you can drive anywhere. Wrong. You're doing wrong. If you can drive in India, you can drive only in India. You can't drive anywhere. People used to say, getting a driving license in UK is more difficult than getting MRCP, MRCS, FRCS. They fail you 100 times. Especially Indian people, our people used to fail miserably in driving schools. We can't drive because we take things for granted. We take things for, so this should have been there before for our students to get international, name, to become a doctor of international repute. If you want to become a doctor of international repute, you should follow the international standards. If you follow the old standard of India, you will sit here, you will have to pass 100 exams, and you will end up paying a lot of money, and you will become old. So now, with that, Bloom's domains, you think, then you do psychomotor, and you feel affective. So think, feel, do. These are the three domains of Bloom's. Okay, this is our regulation. So what happened? The two important things that have popped up are critical thinker and researcher, which was not there before. We have, added communication skills, etc., because this is very important. The word om is said to, stimulate parts of the brain. There is one another word which stimulates all parts of your brain and it awakens your kundalini. Do you know which word it is? Anybody? Wife calling re ellidira. Ekkudunnaavu? Kidhar hai? One in the hospital, patient said, "Sir, I want something to elate me. Give me some time that makes me feel better." And the doctor said, "Wait, the bill is getting ready." Okay, now the ADCOM was introduced to strike the balance. They saw lot many countries, lot of exams to strike the balance, so they added ADCOM. So this is what is important. So we have implemented the longitudinal program. It starts from year 1. It goes till the end of their MBBS. What is most important is 75% attendance, which is mandatory, and 5 to 10 marks of question that appears in the summative assessment. Okay, I will, Madam was talking, about attitude. I put it very simple. It's like a flat tire. If you don't have attitude, you can't move anywhere. So that's all about attitude. It comes from your upbringing. It's there from, inside. So that's what attitude is. Bioethics, Madam has spoken in detail about bioethics. It is, autonomy, beneficence, maleficence, justice. So all that she has spoken about. So this is, so the communication is encoded. You just have to decode it. So it's in a package. So you just have to decode. Can anybody say what he said? So that is where the communication is extremely important. In the Western world, before they sleep, wife, husband says, "Wife, good night, honey." And in the UK, they say, "Sweet dreams." In Japan, they say, "Sleep well." In India, wife always asks husband, "The gas off ಆಗಿದೆಯಲ್ವ?" ಯಾವುದೋ ನಲ್ಲಿ ಓಪನ್ ಆದಂಗಿದೆಯಲ್ಲ, ತೊಟ್ಟಟ ಶಬ್ದ ಬರ್ತಾ ಇದೆಯಲ್ಲ ಒಂದು ಸ್ವಲ್ಪ ನೋಡ್ತೀರಾ? ಕಿಟಕಿ ಎಲ್ಲ ಓಪನ್ ಇದೆಯಲ್ಲ. So now we are talking about communication. So it can be verbal, non-verbal. You either send messages, you speak. It can be verbal. Non-verbal is very important. Non-verbal is extremely important. There is one person, is called Meherbian. He's from University College Los Angeles. He went through and did a study. Only 7% is what you speak. Only 7%. It is not important what you speak. It is important how you speak. 38% is how you speak, and 55% is facial expression. I saw dental madam, so I remember one husband, he went to a dental doctor. He said, hal nota ide, how much estagutte? 1000 ರೂಪಾಯಿ. Local anesthesia ಎಷ್ಟಾಗುತ್ತೆ? 200 ರೂಪಾಯಿ ಆಗುತ್ತೆ. Then he said, sir, local ಕೊಟ್ಬಿಡಿ, ನಾನು ಹೆಲ್ತಿ ಉಳಿದಿದ್ದು ನೋಡ್ಕೊತಾಳೆ. Okay, one fellow came, he said, root canal ಮಾಡಿಸ್ಬೇಕು. And doctor said, ನಿಮ್ಮ ಮನೆಯಲ್ಲೇ ಇದ್ದಾರಲ್ಲ, ನಿಮ್ಮ ಹೆಂಡತಿನೇ ಡೆಂಟಲ್ ಡಾಕ್ಟರು, ಅದಕ್ಕೆ ಸರ್ ನನ್ನ ಹೆಂಡತಿ ಮುಂದೆ ಬಾಯ ತೆಗಿಯೋಕ್ಕಾಗಲ್ಲ ನನಗೆ, ನಾನು ಹೋಗೋದೇ ಇಲ್ಲ. Then after finishing that dental extraction, doctor said, give me 1500 rupees. ನೀವು 500 ರೂಪಾಯಿ ಅಲ್ವಾ ಹೇಳಿದ್ದು ಒಂದು ಹಲ್ಲು ಕೀಳೋದಕ್ಕೆ? ನೀವು ಕೂಗಿದ್ದಕ್ಕೆ ಹೊರಗಡೆ 3 ಜನ ಎದ್ದೋದ್ರು ಕಂಡ್ರಿ, ಆ 3 ಜನ ದುಡ್ಡು ಯಾರು ಕೊಡ್ತಾರೆ? ನೀವೇ ಹಾಕೊಳ್ಬೇಕು. So I remember because I see, yeah. So now facial expression is very important. These are the 3 things. I'm going to talk about, body posture. Extremely important. You look at the body posture of the people and you can find out somebody who has crossed legs is known for information. He is not letting in anything. Somebody with the outstretched legs, bold, he's not taking any of your information. Somebody outstretched hands, closed arms, no for information. Somebody who is bent and bend his legs is curious to know. He wants to know what you're talking about. Okay, now I'm going to talk about facial expression. Face is the index of mind, and eyes are the windows to the soul. Face is the index of mind, and the eyes are the windows to the soul. And you see, the smiling faces will stimulate the speaker. Somebody who is grin from ear to ear. You're not going to talk. Oh, bored. I'm going to end the session. Somebody who's smiling, you are stimulated. It's like tonic. Eye contact, very important. I just have a video on this eye contact. It's actually, staring, and you just have a look at the video.
There are 3 types of eye contact, but only one is effective. Which one do you do? First is scanning. This is where you glance in passing, but never really lock in with the other person. You look away, you look past them. You might even briefly look at their eyes, but not long enough. The second type is staring. This is where you fix your eyes, and even if the other person looks away, you keep staring at them. This is often seen as too intense and combative for some people. And third, the effective way is to go right in the middle of those two, look at the other person's eyes for about 7 to 10 seconds, and then look away for a second or two to create space. Another 7 to 10 seconds, and then glance away. This strikes the right balance between connection and comfort.
So this is all about, so it is scanning and staring. It's between scanning and staring is the eye contact. Then we have touch. Touch is extremely important. Touch will create a bondage between you and the patient. It serves as a critical tool. It gives a sort of comfort to the patient. It alleviates their problem. So you just have to touch. Touch is a form of non-verbal communication. You can see the grandfather once he said, hire young nurses to look after me. And the children asked, Arey, you have become old. Why do you want young nurses? And he says, if you hire young nurses, my children will visit me often. You better, yeah. And one old man was calling his wife, honey, sweetie, Chakopai. And his father asked, Appa, why are you calling with so many names? He said, I have forgotten her name long back. So I'm calling her with a lot of. Okay. So this is all about touch. It's called haptics. Haptics is to touch. Okay. Gestures, proximity, and paralanguage. I have small videos on each of them. I purposefully put it because that's what that strikes the Gen Z. Than you talk. So if they see the video, they remember better.
The power sphere. And the power sphere is the area between your belly button and your arms. When you are gesturing, your gestures need to be within the power sphere. When people are nervous, they play smaller. So what they do is they go, it's great to be here. I'm really excited. I take the full vocal foundation. Can't wait to get to the good hand gestures in 5 minutes. Right? That's below the power sphere, not influential. Up here, influential. Right? You can. And none of you will do this, but just for argument's sake. Up above the head, little bit strange. Okay, so unless it calls for it, you wouldn't really.
So this is the power sphere. Your action should be between this. You do this, no response. Do this, no response. Elon Musk, yeah, big entrepreneur, SpaceX. He always used to say, girls only like people with 6 cars, not somebody with 6 packs. So stop, going to gym. Start working. This is about parallel.
Elements of speech that aren't about the words that you use, but how you use them.
Fine. Totally fine. I don't know why it's coming out all loud and squeaky, because really, I'm fine.
You've heard the saying, it's not about what you say, but how you say it.
Okay, you know who is this chap? You don't know. He's from Friends. You're not watching Friends. My God. Very shameful. Okay, so our olden professors used to say, the change in the voice, the cause of myocardial infarction is diabetes and hypertension. Those voice used to underline, So it is not what you speak, it is how you speak is what is most important. Okay? Okay, proximity is very important. Proximity is called proxemics. How proximal you are to the patient. You just have a look at this.
The space language is called proxemics in communication. Public space, social space, personal space, and intimate space. When somebody enters into our intimate zone from personal zone, that is from one handshake distance to a 2 fist distance without our permission, our body immediately shows through deviation. Watch Melanie's upper body how she is navigating herself to back to the.
So you saw this is very important. You don't want to go to somebody's intimate space, you just want to stay in the personal space, 1 arm distance. Okay? So once student was asking his father, पापा मुझे बुलेट दिला देना. So he said, अरे यार वो लड़की अगली वो घर में बस में जा रही है. She's going in the bus. And why you want a bullet? And he said, अरे पापा मुझे वही नहीं देखना देख सकता हूँ मैं, इसीलिए बुलेट पूछ रहा हूँ. Okay, so communication in medical practice is extremely important. You want to connect with people. You want to, it is internal communication. It is between the nurses, between the staff members, and it is also between you and the patients. It is very important. We are seeing a lot of, fights and assaults on doctors. We are, a creamy society. I was just, 2 years, my son got a seat last year, 2 years of tapasya. You don't get a medical seat just like that. It's 2 years of tapasya, so much of struggle. And you don't want some goons to hit them and go. How can you tolerate? They're all our children. How can you tolerate some outsider coming and hitting your children? Such a creamy society, and they're not exposed to any external environment. They don't know what to do. This is very important. Communication is very important. This is the Bible of NMC saying all about communication. I don't want to go into the details. It is a longitudinal program, year 1, year 2, year 3, and year 4. So they have got the competencies. So everything revolves on core and non-core competencies. There are core 39 competencies and non-core 15 competencies, and there are various domains which are very particular: knowledge, skill, attitude, and communication, and knows how, shows how, and performs. Multiple objectives for each competency. This is all for BCME, so I don't think we need to. Ethics, empathy, and communication. Empathy is very important because there used to be a score in the UK in communication skills only on empathy. Empathy is what will you do when you are in their shoes? To put it very simply, empathy is very important. What will you do when you are in their shoes? That is what empathy means. Okay, it's all been explicitly stated. Important is sensitize, immerse, and reflect. SIR approach. Okay, it's SIR approach. You sensitize them, you dip them in that, and then you ask them to write reflective. Okay, and how do you train them? Brainstorming. As I said before, 75% of attendance is mandatory, and 5 to 10 marks of question in summative assessment. So assessment in CBME curriculum, we have teaching learning methods and assessment. Very important. What are the TLMs and what are the assessments? So these are the assessment tools. We have case discussion, debates, logbooks, reflections, and ultimately summative assessment. We can have a MCQ question. AdCom competency reflection rating. We have what happened, so what, and what next. Professionalism. This is very important. How many of you have role models? Role models are very important. We are not getting proper role models now because of the change. In the past, it used to be guru. Now we have become facilitators. So where are those role models? Anybody? Role models are very, professionalism is that attitude for that profession. So you go to Bangalore, you say, hey, tumba professional agidda doctor. Beligge hode sanjege ella ಮಾಡಿ ಕಳಿಸ್ಬಿಟ್ರು. That is professionalism. Okay, then TLM and assessment for that. Okay, this is very important slide. So we have that formal curriculum, empathy, compassion, etc. Hidden come today's scenario. If you don't talk properly, inadequate communication can lead to assaults, trauma. So we need to save our creamy layer of the society. Okay, yeah. So we don't want to be Mona boys. We want educated, proper learned doctors. Thank you very much. That's it. Thank you.
Thank you, sir. It was a wonderful session, and I think you all enjoyed with many examples. Okay, so sir was telling serious things in a very light way. Okay, most of the things when we practice, we get like this. So always go with the what all the sir told related to the body languages or something. So in our engages, body language was very important. Where I used to purchase a book to see what is this body language and all. So as soon as you see a person, if you have that Mydriatic effect, have you seen Mydriatic effect? So that only shows that you are very much interested. If your pupil size is a myotic one, it shows they are not interested. You are not impressed much for them, right? And also when you are standing, if you are more interested to that person, your leg will be like, it is showing the directions. So many things we used to get in that time only. Okay, these are all very important, and also the doctors. So a lot of problems are occurring, okay, because of improper communication. Okay, that has to be taken care. Okay, so thank you, sir. If you have any questions, sir, you're welcome. Any questions?
Just want to say, because a lot of things in Sanskrit, Satyam Bruyat, Priyam Bruyat, Na Bruyat Satyam Apriyam. Okay, Priyancha, Anamritam Bruyat, Yesha Dharma Sanatanaha. So it is the bitter truth or the pleasant lie. You should not talk about pleasant lie. That is all about that. Okay, thank you.
So there may be many lies, but truth is only one. ಇಲ್ಲೇ ಸ್ವರ್ಗ ಇಲ್ಲೇ ನರಕ ಬೇರೇನಿಲ್ಲ ಸುಳ್ಳು ಹುಟ್ಟು ಸಾವು ಎರಡರ ನಡುವೆ 3 ದಿನದ ಬದುಕು.
I would now like to request Dr. Swami sir to present our memento to Dr. Subramaniam sir. Compassion is often tested most profoundly when words fail and humanity must speak. For our next session, Antim Yatra, Ethics, Empathy, and Grace in the Final Journey, I would like to call upon our moderator for this session, Dr. Lohit K., Professor and HOD, Department of Pharmacology, Sri Siddhartha Institute of Medical Science and Research Center, T. Vedur, Bangalore, and with him, the speaker for this session, Hema C.
Okay, I know it's lunch session now, but I'll borrow only a few minutes of yours and not give a boring lecture. I have a different approach. I think you can all listen to a story, right? Okay. Now, before I begin my session, I want all of you to imagine something. You are a doctor now. You're sitting in front of a patient. You've been treating this patient for quite some time, and now he's come to you. He's sitting in front of you. And now you've recently seen his last reports, and now you know a truth that the patient does not know yet. So, this truth lies upon you now, and how are you going to communicate to him? So, when treatment is no longer working, how do you convey it to the patient? Now, remember, this is my first question to you all. In a few moments, you'll have to answer him. So, remember this question first. What do you do when medicine can no longer offer the cure if patient comes with the pain? Okay, so good afternoon. I am Hema, and my session for today is Antim Yatra, Ethics, Empathy, and Grace in the Final Journey. So I invite you all to walk with me through one patient's journey where we'll discover his journey. So now, this is Mr. Rao. Usually, how do you describe a patient like? On the case sheets, how do we have him? Okay, here is Mr. Rao. He's a 58-year-old hailing from Tumkur and so on. But you should also realize that he's just not a patient on the case sheet, right? He's a person. He's a human being. He's sitting in front of you. More of all, he's a person. He's a school teacher. He's a husband, a loving father to his daughter Meera. He's a person who has now planned his life, but unfortunately, there came a disease in his life, and then came his diagnosis. So he was diagnosed with lung cancer. So there comes the diagnosis. He's undergoing treatment. That he has a hope for it, that something will get better. Okay, so the treatment begins. There's some response, and there's a new hope for him. Okay. Then there's this keeps on going, but then there comes a recurrence. Again, new modality of treatment, and then again a new hope. So this keeps building, and then it continues as a cycle. But until one day, you've seen the latest reports and you see progression. So this is the fight he has gone through. He has fought it. His family has fought it. Even the doctor is fighting. But now the disease has progressed. It is beyond now. So now, when the treatment is not working, this time what do? Do you give him another aggressive treatment? But it has no benefit to him anymore. So now, doctor faces some dilemma. So he is like, what treatment do I prescribe next? No. It should be, what does Mr. Rao need from me now? So now, this is where the doctor's role will begin to change. He has to change from being a person who cures to a person who cares. So, but before we decide that, nothing can be done with this patient, there is one more big challenge for this doctor. That he knows the truth now. He has to reveal it to the patient next. But midway, what happens is he meets his daughter Meera. Now Meera says, Doctor, Appam died to Hairbody. What is she saying? Doctor, please don't tell Appa. He still thinks that the treatment will work. If you tell him, he'll lose hope. Please don't tell him. Now, I just want a quick show of hands. How many of you would tell Mr. Rao that he is diagnosed? How many of you would tell him? Or would you listen to Meera? Which one would you choose? I will repeat the question. How many of you would listen to Meera's request first and not reveal the truth to Mr. Rao? Just show your hands, you need not have to. Oh, fine. See here, there are two things to consider. The patient is the same, the diagnosis is the same, everything is the same. But the answers might be different. Some doctors want to conceal the truth, maybe initially, only for the sake of Meera. But then they may want to also reveal the truth. But the intention here remains the same, that is, they want to protect Mr. Rao. So then, what here the doctor has to really do is, instead of immediately agreeing or refusing to Meera, he'll ask Meera another question. He says, what are you afraid of? What is going to happen to Mr. Rao if I tell him the truth? And she says, he'll give up. And then the doctor enters room. And then Mr. Rao is sitting in front of him. He asks him, Doctor, am I dying? So you're the doctor in front of him. What would you say? You need not have to answer this. Keep this in mind. We'll visit back this question again. Now, in contrast, here Meera has asked you not to tell the diagnosis, whereas Mr. Rao is asking you to tell him the truth. So now from morning you've been listening to autonomy, beneficence, maleficence. They're mere not definitions. You're going to meet this in a room. A person is sitting in front of you who wants the answer. So it's just not definitions. Know that one day you will have to face this. Okay? So just know that. So now you know what is an autonomy. So does it mean you have to forcefully feed that information to the patient? Is that what you have to do? That is not the answer. So now, Mr. Rao, he's going to ask the patient, Mr. Rao, tell me what do you think is happening? And Mr. Rao will say, Doctor, I know there is something wrong. As soon as I enter the room, everyone stops talking. So here you get to know that the patient already knows something. He says that you already know that the family is already hiding the truth from you only to protect you. But the silence has already created that fear in the patient. And now, so what remains is the shoulder. I mean, you as a doctor have to reveal the bad news. It is on your shoulders to deliver the bad news. And that is where the spikes response comes handy. Now, you need not have to follow this sequence at all. Know that so that it can be handy in the moment you need. So in Rao's case, what happens is, before you deliver any information, know what is the perception of the patient. Okay, so perceive what he already knows before you impart the knowledge onto him. So what is the question that the doctor should ask next? Would you like me to explain what the latest scan shows? And Mr. Rao would say, yes, doctor, please go ahead. So the doctor tells him, Mr. Rao, I wish I had a better news. The cancer has continued despite the treatment. Give him a pause here. See, the doctor knows plenty of information. He can give 10 minutes of lecture on what is this cancer, why it has not progressed, what he can do next. But that is not what you're supposed to do. You give one piece of information at a time. Give the space for the patient so that he understands, he can digest what he's listening to. Also check on the patient that if what you have told is he has actually understood whatever information you're delivering to them. Because know that communication is merely not measured by whatever the doctor is saying to you, but then it is measured by what the patient has been able to understand from you. Now we're answering all these questions, and after a moment, Mr. Rao again asks the doctor, so is there no hope? You might get a question that hope here for Rao might be he's asking you for another intervention, maybe another treatment. But no, there is something else behind it. There is an emotion filled with Mr. Rao, and that we name it as fear. So this nurse framework here you see is not mere mnemonic. You need not have to by heart that mnemonic and present in front of the patient. Know that you will have to address him for the emotion he has. So the doctor asks the patient, you seem frightened. Tell me what worries you the most. So this is where all the spikes and nerves or any mnemonics you see on the slides will come in use in the future. Also notice that the doctor is not going to say that, don't worry, everything will be fine. Is that how you're supposed to answer? Or is he saying, you have to be strong, why are you reacting like this? No. Absolutely never use the sentence that there is nothing more we can do. There is still something that you can definitely do. The treatment can fail, but your care should never. So now, after all this, Mr. Rao says, Doctor, ನಾನು ನೋವು ಹೆಂಗೋ ತಡ್ಕೊಂಡ್ಬಿಡ್ತೀನಿ ಡಾಕ್ಟ್ರೆ. Doctor, I can bear the pain, but I can't bear the pain of leaving my doctor alone. So what do you see here? This pain, can you grade it? Can you give a score on the pain scale? Can you just gauge how much pain he is having? You can see you have the physical illness, you can give a score to the pain. But it is a total suffering. He is just not undergoing physical, but also social, psychological, and spiritual pain. So what does Mr. Ram need now? Certainly, yes, he needs symptom care. We are going to give that to him. But that is not the end of it. He also needs treatment for all of the other problems we looked in the previous slide. And that is where the concept of palliative care comes. So what is this palliative care? You need not have to bring it at the end of the treatment. You can do it along, when the disease is progressive. You know that this patient needs palliative care now. It's just not, just because there's another intervention, I'm going to give this intervention. Know that this intervention is not going to help this patient. Give him the comfort he requires at that moment. Now, all this while we've been discussing about Mr. Ram. Everyone goes to his doctor, asks, Meera, how is Appa doing? Is he eating? Is he sleeping? Is he taking his medicines? The doctor also asks, how is his pain? How is he responding? All these things. But there is this one forgotten person there. No one has asked Meera, Meera, how are you doing? Meera, how are you coping with all these things? Have you eaten? Do you need rest? No one is going to ask her. Know that if in Kannada they say, ಅನುಭವಿಸೋರಿಗೆ ಒಂದು ನೋವು ಆದ್ರೆ ಅದು ನೋಡೋರಿಗೆ ಇನ್ನೊಂದು ತರದ್ದೇ ನೋವು. So know that these caregivers, from the family, they have anticipatory grief, fear of loss, the burden of decision making. You're making decision for someone you love. Think how heavy that is. Also, there is one more person in the room who we have forgotten again, and that is the doctor. So the doctor goes to his room and he has one question in his mind. Could I have done something differently? In the future, all of you are going to get this question in your mind. Why? Because as medical students, what are you trained for? You're trained to diagnose the patient, to cure the patient, give as many treatments as possible from your end. But what are you not ready to take in? The death, the defeat, right? So what I would like to mention here is the failure of the treatment is not the failure of care, and it's not the same. So please know to differentiate between it. So does that mean that the doctor has to be completely detached from the patient? No. So what does Mr. Ram need? A doctor who is able to care for him without being, overwhelmed with the emotions. Or he does not want a doctor who is completely numb. He wants someone who is present in between that, who is empathetically present and care for him. Also, when it comes to doctors, I would ask this question: who heals the healer? Because doctor is also going through so many things. Professionalism doesn't ask you to be numb. Professionalism is you can take help. Discuss it with your colleagues. Take help if needed. Because only when you are stable can you treat your patients properly. And now, perhaps the doctor is finally willing to stay. Now the doctor has understood everything. So now he'll ask Mr. Doctor, knowing what we know already, what matters to you most now? Now, what does Mr. Rao say? No one would want to stay in an ICU patient knowing that he's terminally ill. He says, Doctor, I want to go home. So at the beginning of the illness, all everyone thought was, what can we do to Mr. Rao? How can we relieve his pain? But no one asked this question, what matters to Rao most? Who should be with him? Where does he want to be? Who does he want beside him? What is he hoping for now? What are the interventions that he is able to accept? So a good end of life care is entirely dependent on defining what a good end means to a specific person. So also home can mean different to different people. So home can be family or his own personal bed where he can aramsely sleep, a familiar surrounding. Now it can be different for different people. So as a doctor, always ask and please don't assume because his cultural beliefs, his faith is different. Now also there comes a dilemma that medically, ethically and legally what might be correct. So Mr. Rao is telling I want to go home. There might arise another situation where Rao might tell, Doctor ನನ್ನ ಕೈಲಿ ಆಗ್ತಾ ಇಲ್ಲ ಏನಾದರೂ ಮಾಡ್ಬಿಡಿ ನನಗೆ. So does that mean because you're respecting all of his decisions, you are going to help him die? And that is where this withholding treatment and withdrawing treatment, they come into picture. And those two are definitely different from each other. So know what benefits the patient and know what burdens the patient. Now, we have seen about palliative care. So 3 months later, Mr. Rao is at his home. So we have come up with a plan to plan palliative care. Through that, his symptoms are better controlled. But he has spoken to Meera, people important to him have visited. He is weaker, but he is where he wanted to be, at his home. So palliative care did not change where Mr. Rao's story would end, but it changed how he was able to live before it ended. Now, the final night has come. Mr. Rao is less awake. He eats less, drinks less, his breathing has changed. And Meera is frightened. As a doctor, what can you still do? Are you going to make some difference by, okay, I will do something else, I'll do another intervention? No. What can you still do? You can prepare the family. You can respect whatever wishes Mr. Rao had. You can preserve his dignity. And most importantly, be present there. Your presence is more important there. So now, Rao has passed. He died. His journey has ended. But the journey for Meera is still there. She's undergoing grief. And whatever picture you see here, it's just how the person responds to grief. It doesn't give you a sequence that, if it is grief, you have to deal it in a sequence. Is there a right way to miss someone you love? No, right? So this just gives us a framework as to where, the person is. So your job as a doctor is to meet where the person is in this grief emotions. So remember I asked you at the beginning of the journey of Mr. Rao. He also asked you a question. Doctor, am I dying? So do you have a right answer for this now? What are you going to say to that? Maybe there is no perfect sentence to answer this. Maybe what matters is that we do not look away, that we tell the truth without abandoning the person who has to hear it, that we treat what can still be treated, that we see Meera and that we allow ourselves to care without making the patient's death our own personal defeat. Because here, most of the doctors consider that, once the patient has some diagnosis, and then they know that, I can't cure this disease anymore, they're going to let go of the patient. I've heard this story because that patient who cannot be cured doesn't become a jewel on his crown, instead, he goes to a list of failures. So please don't abandon the patients. Instead, walk along with him through that end of life journey. And at the beginning, I asked you, very beginning, first question, what do we do when medicine can no longer offer a cure? So now Mr. Rao has given us the answer. We cannot always cure, but we can always care. So I would like to conclude by telling that perhaps the role of a healer is not always to change where a journey ends. Sometimes it is to make sure that no one has to travel the final part of it feeling abandoned. Thank you.
Now I would like to call the moderator, Dr. Lohit K. Sir, to share his valuable remarks.
Sadvrutta, right? It's Sat. Sat means good, not SAD, sad. Not sad. Vrutta, it is Vritta, not Vrutta, not a circle. If we don't follow Sadvrutta, it will become sad Vrutta. This sad Vrutta will become for everyone. Maybe for the doctors, treating doctors, or for the relatives, patients, everyone. So that's why this Sadvrutta is very important, we should know. Right? And this empathy, what we see always, it's like be present, it's like what, it's not about your knowledge, whatever you have. It's see how they feel. If you are talking to the patient, see what the patient wants, how the patient feeling. If you are with a patient, attenders or family members, see how they feel. So as a doctor, it's not only about knowledge, getting first rank and passing. It's about be one among them. Right? A professor or a doctor, that is, there is a proverb. Atmavat Sat, for every kana, like every kana, like every atom, you should see like as if you are there, you are with them. So in that way, if you fail, then you will realize what pain they are in, how they will improve, like what you want to do. So especially Breaking Bad, it may be the terminal illness or the death. You know, like where exactly you have to tell, and previously Sir has given some videos also how you will tell this person is becoming blue. No, you cannot tell like that. Be, you know where, what is the settings, where you can explain that information, know what the information they already know. So this session actually, like I want to congratulate Ms. Hema, because I was observing during the session, almost everyone was in their own word of thinking like how the patients will. It's like some tragedy movie going on, and like where everyone went through, like they were real observed things are going on, and that is what empathy is. Actually, you are feeling, you are seeing like what the patient was. That was really good, and I like to congratulate her for her presentation as a student, finally a student. And I like to congratulate this entire your own group, that is SSMC pharmacology. I was a part of it. Okay, even like whenever I come, always I will think this is my own team. All these members who are sitting here, like they are all my team only. I always think, okay, Dr. Manjunath was there, Dr. Swami sir, Dr. Naveen sir. Like if you want to know what is empathy, go and talk to Dr. Swami sir or Dr. Naveen sir. Like you tell whatever feelings, they will show you. They will see, and they will feel like then you will realize, because I had to spend a lot of time with them. Okay, and congratulate this entire SSMC team for organizing such a wonderful program where the books cannot teach. These sessions, being involved in it, it is teaching you a lot. So with this, thank you very much.
request sir to please present the token of appreciation to our speaker. I would now like to call upon Dr. Nasima sir to give the memento to our
With the permission of the chair, I just speak only for 1 minute. This is the situation actually you are going to face in reality. When my father was bedridden, he has been admitted in the hospital. His last request was, please take me out of this hospital. It's a good reputed hospital, was bedridden. He has asked me to take to the home. Then I went and requested the doctor, please discharge my father against the medical advice. Immediately the treating doctor said only one word. You being a doctor, you are asking me to discharge the patient at this situation? Yes, this is what the dilemma I had. And I said, I may be the doctor, but I have to be the son for my father. So please discharge. And ultimately, what the last word she has been quoted, that really is a very good. Treatment might fail, but care never fails. So ultimately, when he has been discharged against the medical advice, he was being taken to the home. He was there comfortably, had the last breath. That is the care about. Thank you, Anand.
Thank you, Nagaraj sir. You know this professor? Okay, we'll have a brief introduction from his own colleague. Very down to earth person, very humble person. He has contributed a lot. He's just one among the group. Okay.
Sometimes we feel proud to introduce a person like very down to earth Dr. Nagaraj sir. He is a person holding the maximum number of autopsy done in Karnataka. Maximum number. Okay. So Dr. Nagaraj sir was in Ambedkar Medical College. Then now he is in Sri Siddhartha Institute of Medical Sciences. Okay. He is a professor in forensic medicine. Okay. And the other important is he'll always write in Kannada. Whatever the autopsy report, everything will be written in Kannada. Even all the details, you will go to the in-depth, like if it is a small incision also, you will write what is the incision, and you should see how he reports. Okay. So one important, like majority of the time, like high court, he will be called major for solving many cases, and it's our privilege for him. Like when he saw this Sadhruta program, he came and asked like, I want to come and attend personally, because like even virtual learning, that like personally, if he in presence, if we learn, we can learn more than the virtual. That's why he is here, because like we gave him option of seeing through virtually, but this is his interest to know about outcome of things, importance of outcome. That's why he is here. And I one more big round of applause for him for his presence.
To be frank, I am still a first year student for this session. The reason is I have done the medical law and ethics in the National School of India University, but I have learned to pass the degree. But this session has taught me the physical And really, I have enjoyed the session. I have learned a lot as a student, But still, I am a learner. Thank you, being the students always. I am not a professor, but I am still a student. Thank you, madam. Thank you for a very wonderful session. I am very much grateful to Dr. Nandini. Has been such a wonderful session she had. Thank you very much.
So we are humbled to have you here. See, it's especially AdCom is not about how you dress or how you project yourself. It's about what you are as a person and how eager you learn and upscale yourself. That's why every time I tell every individual, those who score less is also same for me. Those who score top first rank is also same for me, because as an individual you are something unique. So that's what you have to upgrade on. Okay, so not to compare. That is the thing I tell. Sir is the live example to you for today. So thank you so much, sir. We are honored to have you here. Thank you. ಯಾರು ಹೊಟ್ಟೆ ಹಸಿತಿಲ್ವಾ? Okay, let's break for lunch. Okay, please, all of you should come back. It's your batchmates post, so let's be there till 4 o'clock. I do understand. Okay, please, all of you come back, have lunch, and we'll gather here. Come in.
Yes, break for lunch.
ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಕೂಡ ಕ್ಯಾಮ್ರಾ ಲೈವ್ ಅಷ್ಟೇ
Your
ಕೇಬಲ್ ಇದೆ ತಗೊಂಡು ಅಲ್ಲಿ ಹಾಕ್ಬಿಡೋಣ ಕೇಬಲ್ ಇದೆ
ಅವ್ರಿಗೆ ಯಾರಿಗಾನ ಹೇಳ್ಬಿಡೋಣ.
ಪಾಸ್ ಮಾಡ್ಬಿಟ್ಟು ಮತ್ತೆ ಕಂಟಿನ್ಯೂ ಮಾಡೋದು ತಿರ್ಗಿ ಕನೆಕ್ಟ್ ಆಗೋಣ ಕಷ್ಟ ಆಗುತ್ತೆ. ಅಲ್ಲ ಈ ಕಡೆ To summarize, healthcare is a team effort. Communication prevents medication errors.
बहुत अच्छा. वो ये भी पहना था ना, वो भी अच्छा. नहीं नहीं
कौन?
वो पहना है ना धनंजय, वो भी अच्छा
हाँ
दिख
उसका अच्छा है. रेखा रेखा मिस्टर रेखा slide 24
ये फर्स्ट टाइम बनी करा दो.
आई क्या जैसा दिख रहा है ये so much
It's like IKEA, literal IKEA.
Easy, yes.
I'll be here. लॉक कर दिया यार मेरा आईपैड चाहिए मुझे पंकज आईपैड ले ले नीचे से
हाँ सर क्या क्रेजी रिमोट है मस्त है इससे ही चलाऊंगा
तेरा भी है क्या?
हाँ मेरा ही तो है
नहीं अभी क्या?
अभी इसके बाद में मेरा है मिस्टर राव इज होम हिज सिम्टम्स क्या बता मेरे को
यार मुझे मेरा देखना है 1 मिनट
से
पंकज भाग गया
Hey, where's the fucking arrow? बाय एग्जिट करो भाई एरो किधर है There's no arrow.
There must be an arrow.
You also
Fingerprint.
reference it,
Hey, I don't do references. I am my own reference.
Boys का क्या crazy है ना series
किसका?
तेरा
किसमें?
this one is good I'm saying
You have seen
you have
mine?
PDF yeah on
Hey,
that
arrow,
day
arrow
you
बंद arrow
presented
बंद arrow
now.
ले देना
That's different from that
arrow ले दे
Oh, okay. No, I changed it now. I made it Devil's Wear Prada theme. You don't know Devil Wear Prada? It's fine. देखो अब मेरा कुछ ऐसा है. Red and black.
oh
दिखता है मुझे बिना चश्मे का
contact like
Where is my PPT?
When you came there, Monish, side हटना.
अरे 1 मिनट रुको.
अरे मोनीश उस टाइम तो आई नहीं ना
यहाँ से ले लो.
कहाँ है माइक माइक कौन लेके आ
माइक देती.
हाँ
माइक सामने से रख लेंगे ना. हाँ बोलो.
ऐसे कौन देखता है अरे बस
So nice. Should put it into. No, I'm talking about like the lighting, the flowers. नहीं जाओ भाई. पूरा माहौल रहना चाहिए.
बोलिए माइक क्या
Which hairstyle is it?
I don't know today morning
Think like do some action like you're actually concerned something has went wrong. No, take it from a bit.
ये normal लेना बस
ले यार. हाँ ऐसा. अब पूरा दे. Every day.
हाँ हाँ 2x पे
I told you to change it. Questions. Active listening.
communication
Ethics.
attitude
Let me remove that list with Monisha.
कौन सा? मैंने डिलीट कर दिया था. That's just one question. It is not even directed to your group.
case study, pictures, clues, connecting the dots, and rapid fire. Last. पेपर में 5 नंबर पे अल्लाह पक्का फुल सिनेरियो पिक्चर मेरा 9:30 का टाइम था बोलने हाँ अभी 2 बजे थोड़ा लेट हो गया तो इसका भी नहीं हुआ इसका लास्ट सेकंड कीपिंग द बेस्ट फॉर लास्ट
This is not ABCD here.
Huh?
This is not ABCD. Is it one?
No MCQs. Yeah, MCQs is there for case-based questions. Case-based are the easiest. So,
ask.
huh?
Eight cup, huh?
First round.
Tomorrow. Okay. Where, ma'am?
MDJ Saptagiri.
Tomorrow, what do I have? Micro. No.
Anugrah, get out.
Get out! What is wrong with you? What? Tell
Just like act like you are like really into it.
Okay.
Which speaker will do pallu like this and all?
My
Give the pallu.
stomach, bro.
It's fine.
Stomach.
It's not even being seen. Keep both hands on the face. Look this side, no? Don't turn your face completely. Come on, smile a bit, Asha. Cheese. Let me take a portrait.
Can we not?
Okay, you know what? You're giving bitch vibes.
I am. See how he's looking like. Yeah.
This is nice. Mera back.
I like this angle.
Angle, it's the same angle.
But the smile is too much. There's no smile here. I need in between that. That is on me, I know.
Wait.
Okay, this is also nice. Yeah. Okay.
हाँ there ऊपर सबसे ऊपर वाला look there like
Okay. Typing?
yeah
That is nice. Yeah, thank you.
take some more money. I'm not satisfied.
I get so satisfied because I think it's not okay to ask.
Yeah, it's not right. No. Yeah, this is nice.
That's nice. It's roll.
This is nice. You know, oh, this is cute.
This is nice.
There's a black color bag, my dear. Full black Puma.
Puma.
It's kept down. मुझे पता नहीं मनवीत को आना पड़ेगा. Who is this? Someone has left his charge. God, I'm scared. I'm really scared.
Show this.
So the what?
Script है there.
किसका?
There.
अंदर lock हो गया. Yeah, it's really good.
Yeah, get it. Pranav, हमारे picture. हमारे.
The best picture.
Because who's on the frame?
It's because of the people in it. Don't take full, okay? Don't let these things come. Pranav is actually a good photographer.
Yeah, I've seen Pranav's photos.
Is
The background, I don't know. The vibe is very nice.
Bro,
the
the
road
light
is
is.
so
Bro, I need
nice.
photo here, bro.
Okay,
I'm
fine. I'll take it.
Not of me, please.
That orange light. No, it
Yeah.
looks nice. Come on. Now attitude somewhere else you're looking.
What?
Look somewhere else.
I don't.
Now fix your sari, please. Look
Like,
up.
I do that every time.
Now another pose.
I'm bad at
Looking back.
posing, you know that.
Like this.
Okay, fine.
No. Like full down. Turn.
No.
Now full turn. Now turn. Slowly look up to the light. Yeah, look up. Look like that. Look, no.
Stop giving.
See the place. See this. Sadly, I'm not the best.
Yeah, right? What? Yeah.
She'll kill you with the eye only.
Yeah. Academic committee, you're taking photos for me. Yeah.
No, look at the light. The light is no more seen.
Okay. Abhi?
Yeah.
It's projecting on my face.
Bro, this portrait is so shitty, but it's too much of planning you're doing. Yeah, this one only. This one. I'll edit, of course. I'll take out the whitewash. And this one. See the light. We are making the video not get out of here.
पहले तो मेरे साड़ी का बॉर्डर अगर फोल्ड होगा तो पहले बता
Pranav. Yeah? Your phone has really nice camera.
Yeah.
You've not updated it, no? That's why.
Updated.
Completely full updated. Arsha, don't you fake smile? Yeah.
What money?
Yeah. Look at that light, that orange color light.
How?
Turn a bit that side, no? Go where the orange light comes. Ah. Hey, who is that laughing?
It just went.
अरे मुझे बताओ तो.
You give just natural. Turn now, turn. Come front here, sir. Look here.
ये जो आंखों में मेरे आंख अंधी हो जाएगी.
Look here. थोड़ी
अंधी हो गया.
Far. Ah. Up, look. Remove this fucking phone. Oh, mine only. Who is calling me?
First take. I can't stand.
Hello. Yeah, where are you?
अरे मनीष.
Dental college.
आंख अंधा हो गया है. Before
Come
ma'am
to
comes.
dental college and ask for Sabyasachi college.
This is this is nice, but take from far also.
I've taken it.
Only these are nice.
देख यार.
These are nice. See?
Yeah.
My hand.
No, but it looks
Earth
so.
paralysis.
So good. See this one. You live this. See the live of this one.
Yeah, it's nice.
I know.
Take
I'm not an idiot. Catch. By the way, I'm not taking any more pictures. I have presentation.
take her.
बीच में लॉक कर दूं मैं मत कर
अरे
यार सब लोग आ गए ना की लेकर जा सर को देना okay now a bit far look that side
Munish.
this view is also nice
Ah, this is nice.
अब रखो तेरे फोन पे जल्दी आ जाए मुझे प्रेजेंटेशन के लिए but I'm not that kind of person you know like look somewhere
Muskan, huh? Last end में. Oh yeah, these are pretty. Wait.
this one is just sexy
हाँ ये one. Take some more.
like that
मेरा भी ऐसे गाइस मेरे को भी चाहिए मेरा भी मोनी
You will love
होने के बाद अंदर है
you will love this by the way
नहीं मुझे ऐसा नहीं चाहिए मुझे नॉर्मल फोटो चाहिए
नहीं मुझे
प्लीज मुझे ऐसा फोटो नहीं चाहिए मुझे
नहीं,
नॉर्मल
मुझे चाहिए।
अच्छा था लेकिन
पर वो कितना मतलब फोर्स्ड फोटो लग रही है वो
हंस दे थोड़ा
वहां से ले
हंस दे
नहीं,
थोड़ा
पर मुझे वो कैंडिडेट वाला नहीं चाहिए मुझे ऐसा वाला चाहिए यहाँ से ले
अरे हंस दे look somewhere
मुझे भी उधर से चाहिए मुझे भी ये चाहिए सही में अच्छी है
थोड़ी और ले ले फिर और ले Monesh
you people don't even give me credit
yeah, I'll give you credit
I'll give you I'll mention your account also
वो मत कर भाई
Why?
ऐसा नहीं ए डिसीजन कम नहीं कर ली
मैं केली
मुझे भी ऐसे चाहिए उधर
हाँ लेंगे भाई लेंगे सबका लेवल लिखते
पर निकलेगा उसी का यार खड़ा रहेगा ओ वाह शो
देखा ना
that's just a congenital anomaly you know, like it's किसका
पहले उसका ले ले
हो गए उसका
एक लास्ट मेरा एक लास्ट रुक जा भाई एक मिनट हाँ
करो ना फिर
वो ये देख ये
एक मिनट
हो गया उसको लेकर जाओ ना दीदी हो गया ममता दीदी शाल ये ऑन इट ना
क्या कर दिया
हाँ आ गया
बस बस कुछ इतना ही चाहिए
डिसेबल कैसा हो गया
टेक फास्ट
अरे यार बहुत सारे और टीचर्स खड़े give me some other pose Muskan what the fuck is that face you have
what should I do
play with your fucking hair
टेक
ओके ओके हो गया क्या तुम लोग का
ए नहीं हुआ अभी रुक जाओ
see the sticker फोटो ले गई
Shall I tell you one second?
ठीक है करना है
My hair looks like someone burnt it.
that's exactly what I was going for
हटो कुछ Monish don't make faces okay I want from there also I said that one
really give me a fucking
yeah
look here
show ये शुभम में है ಅರುಣ್ ಸರಿಯಪ್ಪ ಎಲ್ಲಾರ್ದು ಫೋಟೋ ತೆಕ್ಕೊಳ್ಳೋಣ ಒಂದು ಗ್ರೂಪ್ ಫೋಟೋ
किसका कहाँ है पंकज पंकज का यहीं पर है देख माउस भी नहीं आ रहा निकाल देगा उसको चार्जिंग
ಸೀದಾ ಬ್ಯಾಕ್ ತಗೊಂಡು ಹೋಗಿರ್ತೀನಿ ಆಚೆ ಜಸ್ಟ್ ಟ್ರೈಪ್ಯಾಡ್ ಹಾಕೊಂಡು ಇದು ಮಾಡ್ತಾ ಇರ್ತೀನಿ ಏನಾದ್ರು ಗೌತಮ್ ಆಯ್ತು ಅಂದರೆ ನಾನು ಕರ್ಕೊಂಬಂದ್ಬಿಡ್ತೀನಿ ಅಡಿಷನಲ್ ಏನೇನು ಹೇಳ್ತಾರೆ ಫೋಟೋಗ್ರಫಿ ಇನ್ನೊಂದಷ್ಟು ವಿಡಿಯೋ ಅದು ನಾನು ಬ್ಯಾಟ್ರಿ ಇಲ್ಲ ಮೆಮೊರಿ ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ದೀನಿ ಸುಮ್ಮನೆ ನೋಡಿ ನೋಡಿ ಅಂತ ಸೀದಾ ಬ್ಯಾಕ್ ತಗೊಂಡು ಆಚೆ ಹೋಗ್ತೀನಿ ಅಂತ
ಹಲೋ ಹಲೋ ಅಣ್ಣ 15% ಇದೆ ಅಷ್ಟೇ, ಅದು ಆಗೋದಿಲ್ಲ ಅನ್ಸುತ್ತೆ.
Now that we have all resumed from lunch, I hope all of you are not very sleepy. For our next session, we have Samanavya Sutra, Professional Teamwork for Safe and Humane Care. I request our moderator for this session, Dr. Manjunath G. N. Sir, Professor, Department of Pharmacology, SSMC Tumkur. Along with him, our speaker for this session, Pankaj Garsha.
Good afternoon, everyone, respected dignitaries, esteemed faculty, and delegates. Today, I, Pankaj Garsha, second year MBBS student from Sri Siddhartha Medical College, going to present on Samanvaya Sutra, Professional Teamwork for Safe and Human Care, which is ADCOM Module 2.4, under the guidance of Dr. Manjunath Ji and sir. Before we begin, let's look at a situation we all know. In India, whenever someone gets a fever, the whole family becomes a healthcare team. One says take paracetamol, another says drink kada, grandma says haldi wala milk will cure everything, and Google says you have a rare disease. Thankfully, in real healthcare, we rely on teamwork and evidence, not family meetings. And that is exactly what today's topic, Samnavya Sutra, is all about. Let me ask you a simple question. Imagine that a patient receives the wrong medicine. Who is responsible? It is only the doctor, only the nurse, only the pharmacist. The answer is everyone because patient safety depends on teamwork. Healthcare is like an orchestra. Even if one musician plays the wrong note, the entire performance is affected. Similarly, if one member of the healthcare team fails to communicate effectively, patient safety can be compromised. Healthcare is a team sport, not an individual performance. By the end of this presentation, we will understand what Samanvaya Sutra means, why teamwork is essential in healthcare, how teamwork improves medication safety, how good communication prevents medical errors, and finally, how compassionate teamwork leads to the human patient care. Samanvaya Sutra is the principle of working together with mutual respect, coordination, and effective communication to provide safe, ethical, and patient-centered care. Without teamwork, many problems can occur. Medication error may happen. Important laboratory diagnosis may be missed. Drug interaction may go unnoticed. Treatment may be delayed. Patient may lose confidence in the healthcare system. On the other hand, when healthcare professionals communicate and work together, patient safety improves, recovery is faster, and patient feels more satisfied and cared for. The healthcare team. A healthcare team consists of many professionals, the doctors, the nurse, pharmacist, laboratory staff, radiologist, physiotherapist, and dietitian, and many more. And finally, the patient and family members are also important members because treatment succeeds only when they actively participate. Let's understand how teamwork relates to medication safety. Doctor writes the prescription, pharmacist reviews it carefully to ensure the correct drug, dose, and possible interactions. Nurse administrates the medicine safety. The patient follows the instructions and report any side effects. The patient then reviews the patient response and modifies treatment if necessary. This entire process requires a constant communication. Let's take an example involves pediatric dosing. A doctor accidentally writes the adult dose for a child weighing only 15 kg. The pharmacist recalculates the dose based on the body weight. The nurse also verifies the dose before administration. The child receives the correct medicine safely. This demonstrates why multiple levels of checking are essential for pharmacology. Next, one useful communication tool is called SBAR. S stands for situation, B for background, A for assessment, and R for recommendation. This structured method helps avoid numerous misunderstandings. Human care. Healthcare is not only about medicines and surgeries. Patients also need kindness, respect, empathy, and emotional support. Even the best treatment may feel incomplete if patients are treated without compassion. A smiling face, listening patiently, and explaining treatment clearly can make a significant difference in a patient's recovery. Imagine a patient admitted to the ICU and with a severe pneumonia. Doctor starts antibiotics. Microbiologist identifies the causative organism. Pharmacist recommends changing to a more appropriate antibiotics based on culture results. Nurse continuously monitors vital signs. Because every member performs their role and communicates effectively, the patient improves. No single individual cured the patient. The entire team did. Unfortunately, teamwork is not always easy. Common barriers include poor communication, heavy workload, fatigue, lack of respect among professionals, hierarchical thinking, and fear of questioning seniors. These barriers can lead to avoidable patient harm. We can improve teamwork by respecting every healthcare professional, listening actively, communicating clearly, double checking medication, encouraging questions without fear, learning from mistakes instead of blaming individuals, and always keeping the patient's welfare at the center of every decision. To summarize, healthcare is a team sport, team effort. Communication prevents medication errors. Medication safety is everyone's responsibility. Compassion is just as important as competence. And finally, the patient is the most important member of the healthcare team. In conclusion, Samnavya Sutra teaches us that when healthcare professionals work in harmony, patient receives safer medicine, better care, and greater hope. I would like to end with this quote. Individually, we save life occasionally, but together we save life every day.
He has understood the pulse of the audience post lunch. So this is the teamwork he has with his colleagues that I will not take much of your time. So he has finished it in a brisk of a time. Okay, but one thing always remember, in any team, who is held responsible? Doctor is responsible. Even if the nurse makes a mistake, doctor is responsible. If patient makes a mistake, doctor. So always you should think of that, and you should coordinate with all the members so that the team works better. Okay?
I would like Dr. Manjunath sir to kindly present token of appreciation to our speaker. I would now like to call upon Dr. Geeta ma'am, HOD Pathology, to present the memento to Manjunath sir. For our next session, Satya Prakash, Honesty, Healing, and Disclosure After Medical Error. I would like to call upon our moderator for this session, Dr. Narasimha Murthy KM Sir, Professor, Department of Pharmacology, SSMC Tumkur, and with him our speaker for the day, Ashish C. Narayan.
Good afternoon to my respective moderator, faculties, and all students present here. I'm C. Ashish Narayanan from second year MBBS studying in Siddhartha Medical College. And today my topic for presentation is Satya Prakash, Honesty, Healing, and Disclosure After Medical Error. To err is human. Basically, this quote says that humans make mistakes, and if the person who's making mistakes generally is a human. Everyone makes mistakes, even doctors make mistakes. But if a doctor makes a mistake, it might end a patient's life or his health. These are some real life cases where a doctor made a mistake. In the first case, basically, the doctor has operated to the father instead of the son. The father was basically waiting outside the theater, so that one happened. In the second case, the patient, the surgery has to be done in the left leg, but they did the surgery in the right leg. Whereas in the third case, they've removed the healthy kidney instead of the affected one. In all these three cases, we can see that the doctor has made a mistake. Now, this is basically the case. In this case, it is a clinic where everyone are busy and it's so crowded in the evening. Basically, a patient named Madhumita, who is 5 years of age, she has come to the clinic to get a booster dose. Whereas the clinic was crowded, the doctor instructed the nurse to fill the syringe with that booster dose, whereas the nurse had filled gentamicin, which was for another patient. The doctor had injected this gentamicin to the patient 5 year Madhvita, thinking that it was the booster dose. In all these three cases, we can see that some error has been occurred. Now, the act of omission and the act of commission. This is basically a broad classification for the errors. Where omission, the word omit says that there has been something neglected or something has been left out. So here, when a healthcare provider fails to perform an indicated action, resulting in a missed opportunity to prevent harm. So like here we can say some examples, such failing to get informed consent, or if the patient is not if the doctor is not taking the vitals properly. These are few examples. Act of commission. This occurs when the provider knowingly he gave the wrong drug or anything like wrong surgery. So the cases which we real life cases which we saw, it comes under act of commission basically. So these are types of medical errors. There are four types mainly: medication errors, diagnostic errors, surgical and procedure errors, and communication errors. Medication errors. This basically involves prescribing, dispensing, or administering the wrong drug or incorrect doses. This we saw in the Madhumita's case, where gentamicin, the wrong drug, which was injected to the patient. And in diagnostic errors, missed, incorrect, or delayed diagnosis comes under diagnostic error. This often happens due to cognitive basis like anchoring diagnosis or failure to order tests which has to be done for that particular patient. Surgical errors. This can range from wrong site of surgeries, which can be surgeries to prevent post-op complications. This we saw in the surgery where the surgery has been performed in right leg instead of left leg. They removed the healthy kidney. That comes under surgical errors. Communication errors. This error is the one of the most dangerous errors. We saw this in almost all the cases. Even in the case of Madhumita, where the communication is not proper between the nurse and the doctor, so that ended up the doctor ended up injecting gentamicin. Why to report and disclose errors? So we know that errors are going to happen and it's not preventable always. So why we are reporting and disclosing is an important question. Reporting and disclosure of errors is critical for patient safety, system development, and ethical transparency. It's not just for bureaucratic requirement like for law and all. It is a fundamental component of ethical medical practice. Basically, when we are disclosing the errors which the doctor has made to the patients, it helps us, it makes the patients to build trust on the doctors and their families who are. It provides an opportunity to identify and fix the system. Always we should correct from the mistakes or errors we made. Same even here, it applies even here where we need to correct or fix the error which we had made. And it allows all the healthcare organizations to implement protocols to prevent similar mistakes from recurring in the future. So this is like a flow chart which shows the difference between reporting of errors and disclosure of errors. So reporting of errors is basically done with the nurses, physicians, pharmacists, other caregivers, etc. Whereas disclosure is done with patients and the families, families of the patient. Both can be verbal, written, and it should be mandatory to report as well as disclosure of the errors. Correct approach to disclosure of medical errors. Truthfulness. We have heard about the quote, honesty is the best policy, which applies here too. So the doctor should be truthful to the patient, vice versa too. Even the patient is truthful to the doctor. So the first and foremost, the patient has the ethical right and legal right to know about the errors affecting their care, which is non-negotiable. Then trust. In this, in medicine, concealment breeds trust. But honest disclosure of all these errors heals it again. So it's a key in maintaining good doctor-patient relationship, the building of good trust. Beneficence and non-beneficence. Disclosure is an act of caring. It prevents further harm and enables timely correction. It is the ultimate form of first do not harm. Respect for autonomy. Patients needs full information about the condition and the error which the doctor has made, which helps in their future care. In the end, disclosure after medical error is not just a legal mismanagement strategy, it is Satya Prakash, that is eliminating the truth. Honesty preserves the sanctity of the doctor-patient relationship, fulfill our ethical duty, and turns mistakes into opportunity to build safer systems. Medical negligence and malpractice. Now we move to the legal dimension. It's vital to understand where clinical errors, if not handled correctly, can cross into legal issues. Medical negligence is a breach of a doctor's duty of care. It occurs when a medical professional fails to provide the standard of care expected of an ordinary skilled practitioner, whereas malpractice is a specific serious subset of negligence. It is where the breach of duty directly causes harm, injury, or death to the patient. Not all negligence is malpractice, but all malpractice is negligence. So these are four D's of medical negligence, which is duty of care, direct causation, the dereliction of duty, and damages. Types of medical negligence. Basically, there are two main types, such as civil negligence and criminal negligence. Civil negligence. This occurs when a practitioner fails to exercise the required standard of care, resulting in injury. The patient can seek monetary compensation for any civil negligence. This can be further divided into active negligence and passive negligence. Active negligence, when an improper or a wrongful action, like administering a wrong medication, is performed, that comes under active negligence. Passive negligence, when an omission or a failure to act, like forgetting to monitor the vitals and vital signs post surgery, this comes under passive negligence. Criminal negligence. This is a far more serious charge when compared to civil negligence. It involves gross, reckless, or willful misconduct that shows a disregard to patients' life and safety. A key example is gross negligence, which is significant deviation from normal standards of care, such as operating under the influence of alcohol. This can result in penal action or imprisonment too. Other types of negligence, contributory negligence. This occurs when the patient's own actions or failure to follow post-medical advices to their injuries. Even when a patient is not saying a history properly, that comes under contributory negligence too. Composite negligence. This involves the negligence acts of more than one party, like both the doctor as well as the patient will be involved in this. Not just them, even hospital, physician, that comes under complementary negligence too. Corporate negligence. This involves when the whole hospital or the uh, whole system does a mistake. Negligence per se. It's an act considered negligent automatically because it violates an explicit medical regulation or legal statute. Okay, these are some precautions that is taken to prevent medical negligence. meticulous documentation. All the medical records should be documented, which will be serving as our greatest defense. We should document all the symptoms, diagnosis, treatments, and the reasoning behind our clinical decisions clearly and contemporary clearly. We should never tamper or alter with any of the clinical notes. Doing so is a guarantee loss in a malpractice suit. We should be honest even while documenting all these diagnosis, symptoms, etc. Informed consent. We should never perform any procedures without informing the patient or getting an informed consent from them. We should we should explain the risks, benefits, alternatives, and potential complications to the patients so that it ensure the patient's life care. At the end, like we should get a sign that is informed consent, consult and refer. Basically, we should never hesitate to seek a second opinion or to refer patient to another physician. If we are not able to treat the patient, it's always better to refer to a better or higher one. Laws and frameworks governing medical negligence in India. So we have mainly like 5 laws such as Consumers Protection Act, Bharatiya Nyaya Sanhita, the Code of Medical Ethics Regulations, Law of Torts, and other specialized acts. Basically, in Consumers Protection Act 2019, this is a primary law used to seek financial compensation for almost all the civil negligences. Patient can file claims in district, state, or national commissions, provided the service was paid for. The Bharatiya Nyaya Sanhita 2023. This replaces the Indian Penal Code. Section 106 addresses causing death by rash or negligent acts. It includes a provision that caps the maximum imprisonment for registered medical practitioners at 2 years, acknowledging the inherent risks in procedural medical procedures. Code of Medical Ethics and Regulations 2002. This was enforced by National Medical Commission. Victims can report professional misconduct, which can lead to the suspension or cancellation of the doctor's registration. Law of torts, an uncodified law where patients can sue healthcare
inside you check some gel, we will take